1 minute.
Hello. Can we? Good evening. Good evening, everyone. This is Mahendra Varman, DGM Sun Pharma, Pharma Care Division. On behalf of Sun Pharma, my heartiest welcome to all the delegates today, and most importantly, the speakers of today's webinar, the panel. I would say that I'm honored and privileged to give this heartiest welcome to all of you because today I have the greatest personality, one of the greatest personality in the ENT world, that is Dr. Satish Jain. And it is my privilege and pleasure to introduce and welcome Dr. Satish Jain, who is well-known personality among the ENT fraternity, not only in the country, in the entire world. And we have with us today Dr. Rajiv Pachori, who is known for who is an expert in advanced surgeries and known for conducting many conferences, especially the Explore ENT in Agra every year. It is his brainchild, and it is very, very significant achievement in his career. And I have one more senior doctor from Cochin, Dr. George Varghese from Cochin, who is a faculty member at the various rhinology workshops, and even at the University of Austria. And we have one more personality from Mumbai, Dr. Parmita Saha, who is a ENT surgeon attached to hospital. So we have great personalities today in our webinar, and we have been requesting Dr. Satish Jain for accepting this webinar invitation, but somehow that we could not conduct. But when I think it has been made possible only because of Dr. Rajiv Pachori, who has really made him convinced to present a webinar today. So once again, my heartiest thanks and my heartiest welcome to all the ENT surgeons today and the panel today. And over to Dr. Rajiv Pachori. Yes, sir.
Thank you, Mr. Varman. Thanks, Sun Pharma, for everything. Good evening, all my friends, colleagues all over from India and abroad. I think there are so many people are going to join us today from all over the world, I think. And I think this is because of the Satish and the team which we have today. So I think, can I share the slide? Can you see the slide now? Yeah, I have shared. Can you see it?
Oh, YouTube का link भेजता हूँ पास.
Okay. Screen share. Okay.
Yeah, it's coming, sir. Yeah.
Okay. Good. So, thank you very much, all. And this is the topic. I think most of us are doing clinical practice. Most of us are doing taking care of all the sinus patient. Most of us are doing taking care of allergic rhinitis, chronic polyposis, and we are managing all the cases with lots of anti-allergic, with lots of treatment, surgery. So many things are there in our mind and being taught by our colleagues and seniors. But I think most of us, I think I would say more than 60% people do not know that what is the basic behind the treatment which we are giving to the patient. And that's why we just chosen this topic, and I discussed with Dr. Satish that how we can teach, how we can tell the people around ENT people that we should know what exactly is the rhinitis, what exactly is allergic rhinitis, what exactly is chronic rhinitis, and what is the best way we can manage those people. So that is the team which we have today, headed by Dr. Satish, and I think we should know. And I will take your all the questions, all the discussion for next 2 hours at least. And that why this discussion is needed here today because of this thing. Because if you go back in 30 years, 25 years back, the concept of sinus surgery was started by Klinger, and assuming that if you remove the disease from the sinuses, if you remove the disease from the ethmoids, OM complex, chambers, mucosal contact area, and once you remove the disease, you clear everything from the sinuses, you should expect a perfect result and ventilation drainage of the sinuses leading to disease clearance, and patient should be okay. They assume this thing, but I think after so many years of this thing, they within year, within 6 months, within 2 years, 5 years, they got some recurrences. And that failure of the surgery, so-called failure of the surgery, in spite of doing perfect surgery, they got the recurrences. That's why the failure of surgery in allergic polyposis or very early recurrence in well-operated, perfectly operated case of CRS made them to realize that they have to go for researches. And this today's presentation, or maybe next 2 or 3 presentation meetings which we are going to have, is a conglomeration of the practical experience of our legends, medical surgical literature, and allergic morphology will be shared here with all of us. And that's why we say, suppose we see any patient in our OPD like this, extensive polyposis, but with typical appearance of allergic rhinitis or allergic appearance in the nasal cavity, we try to avoid these cases because knowing that, okay, if I do this surgery, or if I manage this case, he may not come again to me, or this, suppose I operate, she may get a recurrence. And that is the fear we have to take out from our mind today, that how we can manage this case very well, either with the medical treatment or with the surgical treatment, whatever the best way, that will be discussed. And after doing a perfect surgery, after 6 weeks, 2 months, we get these cases like that. Early polyposis, or you can say cobblestone appearance of the polyposis in all the operated cases. And if we do not manage them very well, they come with the recurrence and clear recurrence. So we have to find out why exactly it is happening. Where is the fault of whether it's fault of surgery, whether it's fault of the diagnosis, whether it is fault of the patient. That we will discuss today. And third, the dream of any ENT surgeon is that how we can get a perfect nasal cavity, what are the criteria which we have to follow that we can get this picture after 6 months or 1 year of the surgery. These are few points. I think all the things will be discussed by all. Dr. Varghese is there, me is there, Dr. Paramita is there, and you all the audience people, please send question every minute, every 30 seconds and 24. And just loaded this discussion with lots of questions. And Dr. Satish is there. He is free to discuss everything, and we have to find out, we have to squeeze out everything from his knowledge. That's why we say that unlike the otology, the sinus surgery is not in the mature stage, it is in the tender stage, because so after so many years, we are still getting new concepts, new modification of surgery, and still we are not sure that our patient is going to benefit 100%. That's why we say it is tender age. And our purpose of this discussion is just to make ourselves mature enough so we can give the best to the patient and give the best outcome that will make this sinus surgery a mature surgery. So that was the main in starting. So I would request Dr. Satish, please let us know what exactly is the sinusitis, what exactly allergy, how we get the polyposis cases, and how we can manage. Over to Dr. Satish. And I would request Dr. Varghese also, sir. Please add some point over here, because the vast experience of sinus surgery, I would like to share with all of you, all of us. Dr. Varghese, sir.
Thank you, Dr. Pachuri. As you rightly said, this is a very, very complex disease. It's not as simple as it appears. Yeah. In fact, allergic sinusitis, allergic fungal sinusitis, it's not something which can be confined or something which we think we can manage with surgery alone. It's an immune complex disease. There's a variety of problems involved in this. So it's you have to have a multi-pronged attack or treatment modality to treat this problem. So over the last decade, there's a lot of newer things has happened in the concept and management and approach to rhinosinusitis, allergic rhinitis, etc. So we have none other than the real moving encyclopedia of ENT, Dr. Satish Jain, whom I consider as my teacher and guru and my boss. I call him boss because his knowledge is so vast that there's no one, to be very frank, I have not met a person who's got so much of knowledge in our specialty. And I'm lucky to be here in his panel. And I'm sure that, as Pachuri rightly said, we'll have to get every knowledge out of him so that each one of you who are listening to this will get the maximum benefit. Over to Dr. Satish.
I think I will request Dr. Paramita. She should take very wonderful. She's the perfect moderator, I think, and she will take very good questions. Anything from your side?
Yeah, so before we start, I would like to tell that this chronic rhinosinusitis, as we all know, it's a huge topic. We cannot cover this topic in 2 hours or 3 hours time. So we are basically dividing this topic into 3 parts. So the first part today that we are going to cover is about the molecular level, the diagnosis, the investigations, when to operate, when not to operate. The basic concepts of chronic rhinosinusitis will be covered today. The second part will be of radiology, CT scan, which will be covered in the next session. The third part will be of the surgery. So that will be the third part. We can cover it in the later session. So today we will start with the first part. And I've already received some 100 questions till now. So you all can ask as many questions as you can, and I'll try to cover as much as possible in this time limit. So over to Satish, sir. We are all eager. So many people are all eager to hear from you for the first time in webinar.
Yeah, Dr. Satish.
Hello.
Yeah.
Yes, sir.
Can you hear me, boss?
Yeah, very clear.
Okay. Thank you so much. And before I start, I would like to extend my thanks and regards to the Sun Pharma team for making this happen. Big thanks to Mr. Mahendra Verman and his team. And it's a pleasure for me to share this stage with people like Dr. Rajiv Pachori, Paramita, and the big boss, Dr. George Varghese. These are the people who have been working in this field for years together. And I'm really impressed with the enthusiasm and the work shown by Paramita in organizing this event. So hopefully it will be an interactive session for benefit of everyone. And Paramita has already shown that she's loaded with questions. Over 100 questions already in place. Hopefully we'll have a good time.
Yes.
Thank you very much for everything. And as Dr. Paramita said, today we'll start with the basics. And I believe understanding the basics is much more important, difficult, and is a pillar behind the success of endoscopic sinus surgery. Like when Messer-Klinger burst this concept of sinus surgery in his phenomenal work in 70s, who devised the theory of ventilation and drainage of sinuses and further propagated by Professor Schamberger. It was so well accepted all over the world. In next 10 years, in the Western countries, it became the standard treatment for chronic sinusitis. It was so popular, and those people were considered like gods. And it is the treatment for the sinusitis, which is not responding to medical treatment. But what happened after that? Thousands of sinus surgeries were performed during that period. And over the period, the surgeons realized the patients are coming back with the same problem. In spite of having opened all the sinuses wide, established drainage, everything, the polyps are coming from the open sinuses. So then the next job for the researchers, for the people to get back to the job of understanding this disease. And that is most important work which has been done in the last 3 decades. Sinus surgery concept, yes, evolved over the period of time with the advancement in technology, with the advancement in, the image guided system, microdevider system, so many other newer systems. Obviously, the surgical technology is evolving, but the most of the work in last 3 decades, which has changed the treatment completely, understanding of disease, understanding of this particular disease, what exactly it is, which has a lot of hidden myths which has to be resolved. So this discussion is directed towards resolving few of these myths with this discussion. As the name applies, sinusitis. This itself is a myth. As everybody who has this name sinusitis means it's an infective disease. It's, believe me, it's not infective disease. It has proven to be an inflammatory disease, not infective at all. And because of this reason, you know what is happening? Majority of the patients with sinusitis worldwide are being treated by the GPs, general physicians, general practitioners, not by otolaryngologists. Majority everywhere, maybe Jaipur, maybe Mumbai, maybe New York, everywhere in the world, majority of the patient initially present to their GPs. And reason being, they do well with the steroids. We'll see in the coming discussion, I'll show through some of the slides, how steroid is helpful at every stage of the cascade of the events in development of sinusitis. That's why that is a preferred treatment of choice. So those GPs, whenever patient coming to them giving steroids, they do well, and nobody wants surgery. For that matter, anybody who has been advised wants to stay away from surgery for anything. That's how this practice has been going on, but that is leading to a lot of issues. So my aim of this discussion is to bring about the facts of this disease, what exactly it is. Like Pachauri sir said, this was the concept propagated by Master Klinger, as I discussed, that clear the ethmoidal pre-chambers and allow the ventilation and drainage of the dependent sinuses like frontal, sphenoid, and the maxillary sinuses. And once sinuses develop good ventilation and establish drainage, they resume to their normal health. It is supposed to be like this. So why this concept didn't stand for long only? As I said, there are a lot of hidden things which are discovered now, which have been discovered, and it is going on. So the first myth in this series is sinus surgery, the ultimate management of chronic rhinosinusitis. And does patient need any further treatment after sinus surgery, or he can get rid of medication? These both the statements are big myths. FES has a big role in the management of chronic rhinosinusitis. We need to understand, but it is not everything. And understanding the disease will evolve how to counsel the patient that FES has a part of management, not everything, and it is a medical disease for which the core treatment is medical. And we need to understand this fact, and that's what I'm going to show you through some of the slides, why it is medical disease and why medical treatment is the mainstay of treatment. Surgery is never the mainstay of treatment, except in certain situations and at certain point of time. So the role of sinus surgery, we need to understand today, what is the role of sinus surgery? This was traditionally, as Master Klinger propagated, ventilate the sinuses, relieve the obstruction, and improve the mucociliary. Yes, it stands true, yet in the present scenario also, it stands true. But after that, as I said, that most of the patients develop this disease back. So sinus surgery has a bigger role now, and that has changed the surgical approach as well. As I said, the steroid is the mainstay of treatment. We'll see in the coming slides. So the role of sinus surgery is more and more to give access to the topical steroids, so that patient can avoid the need of oral steroids. That is the main role of sinus surgery, not only the establishment of ventilation and drainage. And third is, since steroid has a big role, if there is too much of inflammatory load, a lot of steroids will be required, which patient cannot withstand for longer period. So we need to reduce the inflammatory load. If we reduce the inflammatory load, the need of the steroid will be less. So rather than oral steroid, the patient can be managed with a minimal dose of topical steroid without systemic side effects. So the protocol, the scenario for the management of sinus surgery is changed altogether after understanding this disease, what exactly it is. And this is what, see, the patient coming with the polyps, we do the sinus surgery, and now see the concept of sinus surgery. We'll discuss later in detail what exactly this sinus surgery, how it differs from a traditional sinus surgery which was started with. This is not a traditional sinus surgery which is started with. Why? The traditional sinus surgery which Messerschmitt and Stamberger propagated was just to dilate open up the sinus ostia and establish the ventilation and drainage. You were not supposed to do anything inside the sinuses. Now this concept of full house has come in now to more and more give penetration to the topical steroids in the future. If we open up the area very less, if we give a very narrow corridor, the steroid may not penetrate deeply into the sinuses and doesn't serve its purpose. So, in order to serve the purpose of topical steroids coming into effect, we need to really give a wide opening to allow penetration of topical steroids. This is another change in the surgical approach for the period of time. So, the goal is to give access to the topical medication. That is most important in the present context regarding the benefit of sinus surgery. So, Paramita, you can interrupt me anytime. Feel free.
Satish?
Yes, sir. Yes, sir.
Dr. Satish?
Yeah.
You just said that most of these patients comes to us after visiting GPs.
Yes.
And we give steroid to these cases before coming to us. One thing which we have also observed that most of them, or in fact, most of physicians also, they give the nasal decongestant. Their patients comes to it after using many years of this thing.
Yeah,
that is
they get addicted to it.
That is one more issue which I think which we should how to manage those cases. That is one more point I think we should.
That's what I'm coming to in this presentation about the evidence-based management. Okay. So all the use of nasal decongestant have fallen down. The evidence is all against them.
Yes.
Evidence is all against the indiscriminate use of steroids. In our country, unfortunately, there is no regulation or the use of steroids. And majority of the Western countries, there is a sort of a logbook regarding the overall use of steroid doses in the given year. A cumulative dose of steroid given to a patient in the entire year. And that should not cross certain limit to give complications. So the steroid is the mainstay of treatment so far what we have learned, and that's why steroid everyone is using. That's why GPs are the preferred persons the patient interact initially with. They go to the GPs, they are easy to access, they give steroid and they do well. Again and again the patient do very well. What happens if that patient comes to Dr. Pachauri? Looking at the amount of polyps, he would advise a sinus surgery and the patient would never agree. Doctor, that doctor has been giving me medication for years and I'm doing well, and now you are all of a sudden advising surgery. So we need to understand why this is, and we need to propagate this concept even to the GPs in our own towns to understand this disease, not to in this community use steroids. Now, to understand this disease, on this slide, this is a standard definition by American and European Rhinology Society. Why this is important? Once we talk of treating certain pathology, first we need to confirm that are we really treating that pathology? When we talk of management of CRS, we need to first confirm the diagnosis whether it is CRS. And that is the most important part, the most important mistake a people can do, a person can do. The reason being, the CRS is always a clinical diagnosis. The diagnosis is almost always by the clinic on the clinical grounds, and there are certain symptoms. These are 4 major symptoms. If any patient having at least 2 major symptoms, along with some endoscopic finding and CT changes persisting for more than 90 days, is the classical definition, standard definition of CRS. So anything See, there are so many pathologies in the nasal cavity having overlapping symptoms. You need to be very careful that the patient you are treating, where you are directing your treatment, must be having CRS, nothing else. Otherwise, if your diagnosis is wrong, you can't expect a correct, a good outcome. So this definition one should adhere with. We should know what exactly the CRS, and then, as I said, the definition is a clinical one. The diagnosis is a clinical one. We must get into our practice this scoring system, and this has revolutionized our practice. This can prevent medical legal issues. This can lead to actually assessing the disease that you are treating is a CRS. That can be used for predicting the results also. A patient himself can compare his results, what he had given earlier and now what it is given. So for the audience, what exactly this note 22 is scoring? This is a scoring system by the patient. See, these are 22 symptoms, and the scoring from 0 to 5 according to severity is given to the patient to fill this. Now, once you see this proforma filled by the patient, you will immediately realize that he has a CRS or something else. Many of the patients coming with the complaints in the nasal cavity, a headache and all these, psychological patients having neurological issues, some other issues, and they come to you with a sinus problem. That I have a sinus disease, I have been diagnosed sinus disease, and that is further labeled by a surgeon who gets a CT scan and gets some mucosal hypertrophy on CT scan and then confirm put a stamp of sinusitis. So everything, once you go on the wrong path, everything goes on, keep on going on the wrong path. So this scoring system is very important. For example, if in this scoring my patient says, I have a complaint of severe cough, I have a complaint of facial pressure, I have a difficulty falling asleep, I wake up at night, so many other irrelevant complaints which are more severe, cannot be a diagnosis of CRS. That's my point. So that is important to know from the patient proforma that what exactly is suffering from. Now, from this proforma, if suppose the patient falls into the diagnosis of CRS, you give treatment, medical treatment, the appropriate medical treatment, and then you reassess and get the proforma again filled, you will realize what improvement the patient has according to the patient. So the most important part is patient himself is involved in his treatment, in assessment of the outcome. Same thing you can repeat after post-surgery in case the surgery is required, and patient himself can assess what improvement he is having. Now, for example, many of the patients coming with a headache, facial pain, and many of the surgeons, like I said, you get a CT scan from mucosal hypertrophy level as a sinusitis. You must be very careful. Any sinogenic headache can be labeled sinogenic only once you have some endoscopic sign of sinusitis. Maybe purulent discharge, maybe some polyp, maybe some secretion, maybe some mucosal edema, whatsoever, but there must be some clinical sign of sinusitis along with that headache. So symptomatology understanding is very important to prevent reaching to a wrong diagnosis.
You do all your cases this snort score?
Yes, it is most important.
Okay.
And this is a evidence given by the patient to you in writing before he is getting operated for what symptoms he is being operated.
Okay.
No one can deny after that that you didn't have this problem.
Okay.
Okay. So this saves you from medical legal issues also.
Okay.
Now, once you have diagnosed sinusitis, this is a traditional classification we all know, polypoidal and non-polypoidal. This is on endoscopy. If you see the polyps, polypoidal. If you don't see polyps, purulent secretion is non-polypoidal. Yes, it has a value. No doubt it has a value. The reason is the polypoidal has a different inflammatory pathway than non-polypoidal altogether. Polypoidal is mostly driven by the T helper 2 system, eosinophilic system, and this non-polypoidal is predominantly neutrophilic system, or less eosinophilic, you can say. So, but this is not enough. All sinusitis cases coming to you cannot be treated on the same line. Why I have put up this slide? The reason is the goal of our treatment is to give patient a cure. Many times you are doing your best, but still the patient is coming back with a recurrence. The reason, every time if you go into the depth, you'll find the reason there is something which is missing. So now if you go to the current research, the more and more work is going on to find the particular endotype of sinusitis. Now, a lot of endotypes of sinusitis have been defined due to understanding of pathophysiology much better.
So would you recommend an allergy skin prick test or something in these cases with polyposis? Dr. Vikram Khanna is asking this question.
Yes, allergy is a strong association. Dr. Vikram Khanna is working a lot of work on allergy. This question is valid. Allergy has a strong association in polypoidal sinusitis, in eosinophilic mediated sinusitis, in T helper 2 cell mediated sinusitis. Has hardly any association in non-polypoidal sinusitis. And see, what is the significance? If the symptomatology of allergy and sinusitis is overlapping, we all know. You operated upon a patient with sinusitis and ignored the allergy. What is going to happen after a period of time? Say after a few weeks, patient will come back to you, doctor, my surgery has gone failure. I got operated for this nasal problem and I have been suffering for last 7 days with the same sneezing, same block sensation, same headache-like feeling, heaviness, and same thing. I think the operation has gone complete failure. If we assess these patients preoperatively properly, I will tell you in the next coming slide about the diagnostic which is needed before surgery to reach to a correct level of diagnosis and to correctly identify the comorbidities. So if you don't ignore the allergy, you can tell your patient pre-op that this is the disease and you have comorbidity of allergy which will require treatment later on. And like Dr. Paramita said, will require skin prick testing and immunization, which is the only treatment which can change the natural course of disease. So identifying these comorbidities is important. Now, why I said with the understanding of pathophysiology, now in the current research, variety of endotypes of sinusitis have been described. And every endotype has a different pathophysiology. So you have to accordingly tailor your treatment to the particular endotype. It cannot be that every sinusitis can be indiscriminately treated with the same treatment. It cannot work. Like for example, if the patient has a AERD, aspirin exaggerated respiratory disease, I will come in the coming slides how different it is in pathophysiology from other sinusitis. It is one of the most severe form of sinusitis, polypoidal sinusitis. And if you miss this diagnosis of AERD and don't treat on the line of AERD, it's a different endotype of sinusitis, a good result cannot happen. I have treated a patient who had been operated 22 times. The difference is in 22 times had AERD, was never diagnosed. Once we diagnosed the AERD and subjected him to aspirin desensitization, is doing so well. So try to understand, it can happen to anybody. If we are not getting good results, the simple meaning is we are missing something. And the goal of this presentation is to apprise you how complex this sinusitis subject is, how complex the interaction is, how important are the comorbidities. It's like a syndrome. If you miss one thing, the end result is an utter failure. As simple as that.
In your practice, this aspirin sensitivity cases, how much percentage you get in your failure cases, or just roughly how much percentage is there?
For desensitization, 5 to 10%. Polypoidal sinusitis, 5 to 10%. I am coming to that endotype later. We'll discuss in detail, but this is fact. See how much of the patients have been missed. Yes. Imagine this sinus surgery is getting bad name or has got bad name only because of the so-called recurrences. Yes. Even a layman coming to you for sinus surgery, who has been advised sinus surgery by some other surgeon, coming to you, his first question would be, doctor, will it come back? I have heard that it comes back and you need to get operations again and again. I have Googled and I found the recurrences are very high. Many of the patients Google so frequently. So the bad name to this disease is only because of lack of understanding of these concepts. So as I said in the beginning, the pillar of the success in sinus surgery, post surgery, depends upon understanding of this disease. Whatsoever good surgery you have done, the best surgical work you have done, if the pathophysiology of that particular patient is not understood and treatment is not directed according to that, the success cannot come. So there are variety of endotypes. We'll discuss in detail why everything is important and how the treatment is different for different endotypes. It's not that every sinusitis should be treated in the same line. It cannot work. So to understand this sinusitis, yes, any question?
Yeah, I want to. Does this regional variation affect the, we are in this part of country, North India, Dr. Varghese is in south part, where the humidity is more. Someone is on the eastern India, does it make a big difference?
Yes, yes, it does. In humid areas, the fungal disease is more common. I'll come to it when it comes to fungal disease, but your question is important, valid, and you see everywhere in the world. In the humid areas, the fungal disease is more prevalent. And fungal in different ways. All fungal disease is not same. Sometimes they lie on the mucosa, faulty mucociliary clearance. Sometimes the host reaction leading to problem. Sometimes there is immunocompromise and they invade. So the fungus react differently in different areas according to the patient's immune system.
And so Dr. Smriti from Assam wants to know what is the relationship between vitamin D and the chronic rhinosinusitis with polypus.
Coming to. Yeah, that's what, see this slide, immunity I am coming to. Yes. The whole game of understanding sinusitis, I can tell in nutshell, it is an immune disorder. As I said in the beginning, it's an inflammatory disease, not infective disease. God has given us a strong sinonasal immunity. Anything, any fault in the sinonasal immunity would lead to this problem. For that matter, anything which improves the sinonasal immunity will have a positive impact on the outcome. And anything which is detrimental to the sinonasal immunity will have a poor outcome. As simple as that. And that's how the vitamin D works. I'll tell you how vitamin D has a positive impact on the sinonasal immunity by various, its work at the cellular level, how it improves the sinonasal immunity. So first, in 2 or 3 slides in brief, I'll throw some light. It may look complex, but it is very simple to understand and essential to understand the whole game. What is sinonasal immunity and what is the future of treatment? Because if you understand this cascade of events, we can easily understand what is going to be the future of this disease. Future is never going to be surgery, surgery, surgery. Never. Like cancers we see, most of the research work in the cancer is going on at the molecular level to understand the targets. Same thing in the sinusitis. The work is more and more going at the molecular level and we have found certain targets. If the disease is stopped at the initial level by blocking the working of those targets, targeting that level, you can prevent clinical manifestation and the sinus surgery is not required. And that is probably going to be the future, not very soon, but yes, in times to come, that is going to be the standard treatment and that is all because of the understanding this disease. Dr. Varghese, you can interrupt me anytime.
So how do we diagnose these different endotypes?
Yes.
Dr. Sumanta from Amritsar wants to know this.
Yes, yes. When I come to all endotypes, that's a very important question, which I'm going to answer. Endotype means that particular endotype has a different pathophysiology. I'll come, go to the previous slide. I'll go to all these endotypes one by one to show you what is the difference in the management of these 5. How to diagnose these 5 separately. Like for example, at this stage, any patient with a nasal polyposis, having asthma must rule out AERD. Up to 15% of the patients with polyposis having asthma have aspirin sensitivity. That is how you can diagnose. And if you elucidate the history from the patient is good, he can tell you, yes, he has a reaction with What are point? Cystic fibrosis, how you can diagnose it's a different endotype.
1 minute. Sir, just a minute, sir. Anyone else is logged in through Zoom account close to you? Next, someone, because just getting an echo. Some other device. No,
Me?
I think. Okay. So carry on, sir. Carry on.
One question is there.
So like cystic fibrosis, Madam was asking about how to diagnose this.
ARD,
For example, any child coming with nasal polyposis, multiple bilateral polyposis in a child, to me, is almost always a cystic fibrosis unless proved otherwise. And if I don't consider this and go on doing a sinus surgery like considering a polyposis, it can never work. Because this is a genetic mutation in a gene leading to faulty chloride channel, leading to the thick viscous fluid, and that is leading to the blockage of the mucociliary activity. That's a different pathophysiology that has to be targeted differently. We cannot treat all patients on the same line. We need to pick up for that particular patient, and for that, I'm coming with a diagnostic list. We need certain tests before going for the surgery. We need not to rush for the surgery. The moment you see a patient with a polyp and you plan surgery, it can never work. Once you see the patient with polyp, we need to do certain tests, not only for the diagnosis, to rule out some other diagnosis, to find out some other comorbidities. If we ignore the comorbidities, again, the results are never going to be good. So those tests are important and to prognosticate.
Yes, sir. So these tests will also help us to decide how long we can give the post-operative steroids.
Exactly, to prognosticate. If the patient asks me how long I need to irrigate my sinuses post-operatively, you need to have some answer. So we need to have an answer. We should be able to give answer. So answer is we need to see your disease level profile. Then only we can say. When we operate, we'll get histopathology to see how much is tissue eosinophilia. That will dictate. Like when you operate on a cancer patient, neck dissection, primary, suppose tongue neck dissection you have done, need of chemotherapy, need of radiotherapy will be decided on the final histopathology. How many nodes are there, how many levels of nodes, if there is extracapsular spread, so many criteria. So you need to have certain thing in your hand, reserved for such answers. You cannot give straightforward before surgery that how long you are going to irrigate. That's why tests are important. So now these 2 or 3 slides is to understand what exactly we are dealing with. Yes, boss.
Yeah, one question is there from Dr. Rajan Bhargav.
Yes,
how often you operate non-polypoidal cases and what are the outcomes? Yeah, we discussed about this.
Less than polypoidal, the very important question that will be covered in the medical management part. Non-polypoidal sinusitis can now in this era mostly be managed with a medical treatment with the introduction of macrolides now. Majority of the patients can be tackled non-operatively. Majority. Still, some patients do present with complications. Many of the non-polypoidal sinusitis present with orbital and cranial complications. You know, this is surprising. Polypoidal sinusitis can, in the severe polypoidal sinusitis, can give complications, orbital and this, but non-polypoidal very frequently give complications. Okay. Majority of the polypoidal, the orbital complication in children is because of non-polypoidal sinusitis. Orbital abscess, subperiosteal abscess, cellulitis, all because of spread of infection that is not polypoidal. So non-polypoidal, yes, we need to operate, but less frequently as compared to the polypoidal one.
So Dr. Sanjeev Golhar from Nagpur wants to know that if we avoid aspirin, can that cure ARD?
To avoid?
if we avoid aspirin, can that cure AERD?
No. So aspirin you can avoid, you can prevent the exaggeration of disease to certain extent. Whatever treatment you give, you operate, can work to certain level, you can prevent exaggeration to certain level, but that cannot change the pathophysiology. So to treat the underlying pathophysiology, you need to give aspirin. You need to desensitize. I am coming to that particular entity. So now, to understand this whole game, we need to understand this next 3 slides, because that is going to be the future targeted therapy. So what is sinusitis? What God has given us a sinonasal innate immunity, as I told you, it has 3 parts. Our sinonasal immunity, why it is so important? Because our nasal cavity is exposed to so many challenges all the time, with microbes, allergens, dust, fumes, particles, so many things we can inhale all the time. And God has given us this sinonasal innate immunity to combat with all these challenges without giving problems to us. So it has 3 parts. The number 1 is the intact epithelium with tight junctions. So sinonasal epithelium is intact pseudostratified columnar epithelium with tight junction. That is number 1 barrier to prevent penetration of all these challenges inside the mucosa. Number 2 is the mucociliary system. Whatever challenge, microbe, allergen, whatever coming to the nose is taken up by the mucus, the mucociliary system, and expelled in the nasopharynx and then to the gut, preventing entry into the epithelium. So the mucus and the ciliary activity has an important role. The quality and quantity of the mucus has a bearing on this. And third is our sinonasal epithelium. It secretes more than 1,000 variety of entomicrobial proteins, enzymes, so many things to combat particular specific challenges. So in a normal individual, when all 3 work together, we are protected from any damage to the sinonasal mucosa and consequent sinusitis. Is that correct? Now, once your sinonasal immunity is impaired, what can happen? At any of these 3, if it is impaired, we face with a challenge like sinusitis. What happens? If this 3 system is impaired, whatever the challenge invades the mucosa, it is taken up by some receptors in the mucosa known as pattern recognition receptors, and those activate the adaptive immunity further. So these are some important proteins secreted by the epithelial mucosa. More than 1,000 varieties, everyone made to combat certain specific challenge, and more such are being discovered now. That is the level of this work going on. Now see, whatever antigen taken up by the pattern recognition receptors. Can you see here? Is it visible where I am working?
Very clear.
Yes.
These pattern recognition receptors, they are stimulated by the thymic specific lipoprotein interleukin 25 and 33 and presented to the innate lymphoid cells. This is important. And this is the station. This is the main station where the further things happens to occur. Because according to the type of challenge, according to the type of antigen, the lymphoid cells will start a next system. T helper 1, 2 or 3, what kind of lymphocytes are going to be activated. So suppose the most important is the helper 2 system, eosinophilic system. They activate the T cells which secrete interleukin 4, and that activates the T helper 2 system. Once this system is activated by means of interleukin 4, 5, 13, the eosinophils are activated, and eosinophil give further damage to the mucosa. Now the dysregulated immunity starts, interleukin 4 and 13 are secreted, B cells are activated, immunoglobulin is secreted, and that leads to a lot of damage to the basophils and mast cells. So this is how, once the antigen invades the mucosa, the immune system gets activated and variety of steps are taken place to give further damage to the mucosa and submucosa. This is the basic understanding. So this is one thing, one This is most accepted theory of sinusitis. Why I am showing all this unnecessarily? Because now a lot of targets have been identified to block this entire cascade. Coming to the next slide. Next slide. Yes. This is another theory. This is very interesting. And this is again picking up quite well. And this is acceptable to certain individuals. Bitter test receptor theory. There are hundreds of publications on this theory. I don't know how acceptable it is, but yes, it is. And they have the proposed hypothesis is there are certain gram-negative bacteria which secrete these lactones. We have a bitter taste receptor in our nasal cavity along with the oral cavity, T2R38. And these receptors are activated by these lactones to open up the calcium channels which secrete nitrous oxide. And nitrous oxide is antibacterial. It is protective. It improves the ciliary bead frequency, improves mucociliary clearance, and protects from these bacteria and further damage. So those people who are having mutation in this receptor, T2R38, there's a bitter taste receptor, are more prone to develop sinusitis as compared to the people who have a normal T2R38. Means those who are good bitter testers are protected from sinusitis. And I'm sure Pachauri boss is a good bitter tester.
Well, I have gone through many literature and it is very much proven now.
It has been proven now by a lot of studies. Those who are bitter testers are relatively protected from sinusitis because of the protective effect of nitrous oxide exerted through the by means of opening the calcium channels through these bitter test receptors.
Alcohol addiction, and this thing has been correlated very well over there.
Yes. So now this is the cascade again. Why I'm coming to this? The first level of success the people get in blocking this TSLP and interleukin 25. If we block by means of monoclonal antibodies, the entire cascade of event can be stopped. What's my point? The entire event can be stopped if we have a monoclonal antibody blocking this step. If we have a monoclonal antibody blocking interleukin 4, 5 and 13, what can happen? The entire cascade of event can be stopped. What the patient will see with a polyp is the end result of clinical manifestation. That this disease can be stopped very early at the molecular level if we have the targets and a therapy for these targets. So we have now understood these targets very well. That's why I wanted to show this slide. These are the targets which have been understood, which have been picked up, and monoclonal antibodies have been developed. Lot of clinical trials have been done, and many of them now got approval from FDA. Many of them are being used to treat severe asthma because asthma also has the same inflammatory cascade. The same interleukin cytokines are involved in the asthma like in the Th helper 2 system. The eosinophil, interleukin 4, 5, 13, IgE all are involved in the same development of asthma. Asthma is what? Sinusitis is what? Sinusitis is asthma of the nose. Asthma is lower airway. Sinusitis is upper airway. We have unified airway. The disease, the chronic inflammatory disease affecting the lower airway is asthma and affecting the upper airway is sinusitis. And the cascade of event is almost same, leading to destruction of the epithelium and subepithelium tissues by means of eosinophilic and IgE activity. So these are the targets have been identified now, and the future of sinus surgery now, the future of this sinusitis now is going to be this targeted therapy. You can block these targets to prevent clinical manifestation, so the need of sinus surgery would never arise. Now the question is, see this, more and more research work is going on finding new targets. So these are the monoclonal antibodies which have been approved by the FDA. If you block the IgE monoclonal antibody, ligelizumab, approved by FDA. These are anti-IL-5 receptor 413 antibody, dupilumab. This is the first monoclonal antibody which are approved by FDA. Dupilumab. And They've been used. Long-term results are encouraging. A lot of people have done variety of research work. A single dose of omalizumab and mepolizumab gives amazing symptomatic relief, long-lasting symptomatic relief, but we don't know the long-term complications. We don't know the long-term durable results. All those are still pending. That's why they are not so popular for the routine clinical use. The cost is again a limiting factor in the present scenario, but hopefully in the coming time, the cost will come down. And they may be more popular for the routine clinical use once the long-term safety is established. So if you block any of these targets, the further cascade of events can be blocked. Until now, at every level of this cascade, at every level, the only thing which works is the steroid. Steroid improves the epithelial junction, steroid improves the mucus layer, steroid improves the ciliary beat frequency, steroid down-regulate the interleukin 4, 5, 13, Ig, everything. At every level, the steroid works. So why I am showing this? In the present context, the only weapon we have as far as medical treatment is concerned, because it is a medical disease. So the only weapon we have is the steroid, because it works at each and every level of this sinusitis cascade. Now, coming to the diagnostic part, we all know generally we do nasal endoscopy and CT scan for the diagnosis and take up the patient for surgery. In general, why these unnecessary investigations are important? This is to throw some light, as you asked about the vitamin D. All these investigations, if you bring in your practice, has some bearing on the outcome. For example, like you asked for the aspirin sensitive. It doesn't mean the entire list is required for every patient, but you have to choose out of it for particular patient. If the patient gives history of asthma along with polyposis, who has polyposis, we must think of aspirin sensitivity testing. Most of the time you can elucidate with the history and patient can tell you, yes, he has this problem of reactions with the painkiller sometime, and then you are more focused towards the testing. This testing can be done various ways. I will tell once I come to this point with AERD. But this is important. If you ignore this, how many times you operate on a patient with polyposis having AERD? You operate 100 times, it is going to come back. It's bound to come back. Because the natural disease process driven by the leukotrienes is going on. You need to tailor a treatment to the underlying molecular pathophysiology. Same is IgE. A lot of people ask, why do unnecessarily get IgE done? IgE is one of the most important tests before doing a sinus treatment, maybe sinus surgery or medical treatment. I have three bearing or three aspects I look at once we get the IgE done. Number one, patients who have a high IgE are eosinophilic patient, eosinophilic driven disease. Patients who have a low IgE, unlikely to have eosinophilic disease, and those are the patients we benefit most with the macrolides. So patients who have low IgE, you can keep them on macrolides for the response. As Pachori was asked in the beginning, Dr. Rahul asked, Rohan asked from Kanpur, is it?
Yes.
His question was, when this non-polypoidal sinusitis is operated, the majority of the non-polypoidal sinusitis can be treated with a medical treatment provided the serum IgE is low. That is second bearing. Third is, if we have a very high IgE, very high, it gives indications either the patient is severely allergic to something or the patient has a concomitant Staph aureus infection which leads to superantigen and polyclonal expansion of IgE. So IgE is most important before taking up the patient for any treatment, medical or surgical.
So
if you ignore this fact,
if the Ig is high, sir, will the macrolides work then?
No, no way. There is no role. At least you can rule out the macrolide from the treatment list.
Yes.
If there is high Ig.
Yes.
So everything is important. As I said in the beginning, this is not an infective disease. Name implies like infective sinusitis. And it's a practice by the GP, general physician, even the ENTs to do antibiotics.
Yes.
There's no role.
Yes.
Unless there is proven bacterial infection. So how you can rule out? You can get a CRP or Procal. CRP is much cheaper. A normal CRP rules out the bacterial infection and need of antibiotics.
Yes.
There is no point in giving antibiotics for these patients.
And so, what about the serum eosinophilic count? What is that? What is the role of serum eosinophilic count?
Serum eosinophilic count has a predictability.
Yes.
See, eosinophilia is the main factor. I mean, directing the post-operative treatment, dictating the treatment, I would say. Now, you cannot get a mucosal eosinophilia report unless you have a histopathology. Pre-operatively, yes, you can have a serum eosinophil report, and that is, I would say, correlating with the mucosal histopathology report. So you can have an idea, gross idea with the eosinophil count that the patient has a T helper 2 or a eosinophilic disease.
Yes.
So like CRP, as I was saying, why I'm mentioning this small thing at this level, this is most important. Because in sinusitis, it has now been proven that the commensal bacteria in the nose are protective. They prevent the growth of the pathogenic bacteria by means of working with the natural immune system. If we give unnecessarily antibiotics at this level, that prevents the growth of the commensals. And the pathogenic bacteria rather would grow in spite of being given antibiotics. Because antibiotics, whatever you are giving, are broad spectrum. Even if you are doing culture-directed antibiotics, those cultures are never reliable. Because the only thing by means of which you can get a complete information about the pathogenic bacteria is the gene sequencing, not the culture sensitivity. And that is not practically possible in the clinical setting. In culture sensitivity, you get to know one bacteria. There could be sometimes multibacterial infection. So you cannot rely on culture so much. So CRP is important to avoid unnecessary antibiotics, because those unnecessary antibiotics without infection have a detrimental effect on the nasal commensal bacteria, which are helpful for the prevention of this disease. So this is the list of investigation you have to choose according to the patient out of this list. I'll come to this. Now, vitamin D, to answer your question.
Sir, just I want to interrupt. The Dr. Kaushal Sheth wants to know that these monoclonal antibodies, are they available in India? And
yes, available, but not widespread in use for this purpose. I've already mentioned. Convey my regards to Dr. Kaushal Sheth. Hello, boss. Number one, limiting factor is the cost. Physicians do use for the severe asthma or status asthmaticus sometimes. The first is the limiting factor is the cost. And second, for this benign disease, unless and until we have a long-term results ruling out any bigger issues with these drugs, we are hesitant to use this. So that's why I mentioned in the beginning, in times to come, maybe 5-10 years down the line, they are going to be the established treatment.
Gaurav Medicary from Vancouver is saying that most of these monoclonal antibodies aren't officially allowed by the ENT surgeons to be prescribed. They are targeted for asthma. Only Dupilumab has been approved for sinusitis.
Yes. So Gaurav Jinda hai?
Yes. He's asking many questions to you, sir.
Vancouver. Gaurav, hi. Gaurav is a champion surgeon, and I've been so fortunate to have him at my center. It's amazing. We have done a number of publications together, written number of chapters together. At a great time for Gaurav. You're right, Dupilumab was the first monoclonal antibody approved by the FDA. Now, regarding the use for approval for the use for sinusitis, omalizumab and mepolizumab are also approved. But now with the dupilumab has an advantage. It is actually the interleukin-4 receptor blocker antibody. And it has a dual function of blocking interleukin-4 and 13. That's why it is the preferred treatment for eosinophilic sinusitis rather than anti-IgE omalizumab or mepolizumab for interleukin-5. Because this dupilumab serves the function of both most of the time in eosinophilic sinusitis, as it blocks interleukin-4 and 13-4. That's why it is the preferred monoclonal antibody, you can say. Okay? Yes?
Yeah, this you just said we can use macrolides in non-polypoidal cases. Any role of doxycycline in sinusitis?
Yes, I have a slide for that. Doxycycline has a huge role. It has been proven now for the polypoidal sinusitis, not for non-polypoidal. Doxycycline, yes, boss?
Can you hear me?
Doxycycline has a role in polypoidal sinusitis by means of its anti-inflammatory effect on matrix metalloproteinase. It has an effect on the nasal polyps. It has been proven now, and in the list of medical management of polypoidal disease, in the list of appropriate or complete or total medical management of the polypoidal disease, doxycycline is one of the viable options to add on. We always add doxycycline in the medical management of polypoidal disease before operating. And it works.
You were just saying that, can you hear me?
Yeah, we can hear you.
Yes, boss.
You are saying that antibiotics will...
yeah, so doxycycline working as an immunomodulator, not as an antibiotic. Macrolides are being used as immunomodulator, not as an antibiotic. I have a slide, I will tell you exactly at molecular level how doxycycline helps in polypoidal sinusitis. Okay,
sir, can you go to the previous slide once again and can you tell us more? There are few doctors who wants to know the exact role of serum eosinophil count again. Like what should be the level?
Serum eosinophil count gives you a correlation with the mucosal eosinophilia. It is not so sensitive and reliable, but before having histopathology in the hand, you can at least have an idea with the serum eosinophil count if they are extremely raised that the patient has a eosinophilic disease which will require a long-term treatment later on. You can tell your patient. It doesn't have any other significance. The final value is of histopathology, which I am coming after this slide, which is a big role in eosinophilia assessment. So coming to the vitamin D, I will come to that question of eosinophil count again after this slide.
Okay.
So why vitamin D? In literature, you will find a lot of publication saying pros and cons about the vitamin D. Lot of publication against the value of vitamin D. Lot of publication favoring vitamin D for many things. In sinusitis, vitamin D has an important role, and what most important role we are using for is vitamin D improves the sensitivity to the corticosteroids, and this is an important bearing. We have seen in our practice we have a habit of getting vitamin D done in many of the sinusitis patients, and we have seen extremely low levels of vitamin D in many patients, and those are having severe bone erosions. We have supplemented and they have done well. And the most important thing is improving sensitivity to the corticosteroids. As we all know, in the present situation, the one and only weapon we have to combat this disease is steroid. And imagine a situation you are giving patient steroid and those are not working. And that is the most important role of vitamin D, to improve the sensitivity to the steroid. If you are giving steroid to the patient and yet those are not working, is a most difficult situation, and then you need to think of something else. And that's how vitamin D works. And it has a role at every molecular level in improving the sinonasal immunity. As I said, there are more than 1,000 varieties of protein secreted by the epithelial cells. Vitamin D increases antimicrobial protein secretion. Cathelicidin, which is one of the most important proteins. It reduces the eosinophilic activity. It reduces the activity of the T cells. So many levels, it is very, very important. Histopathology, this is a format which we have been using. This is my humble suggestion who are doing sinus surgeries to get a representative specimen of the nasal mucosa. If patient has a polyp, preferably a sample of the polyp. Otherwise, a sinus mucosa which is showing some changes like thickening, edema, cobblestone appearance, whatever. To take a sample from there and send for histopathology to get eosinophil count in the mucosa and the thickening of the basement membrane. These are two important factors dictating the future treatment, post-operative treatment. That's how you can tell your patient how long they will need steroid irrigation. Depends upon their histopathology report, depends upon the disease, how severe the disease is, accordingly will direct. So it has been proven those patients having eosinophil count in the mucosa more than 10 eosinophil per high power field will require almost a lifetime steroid irrigation. The value is why irrigation? As I said in the beginning of the role of surgery, steroids, after the surgery, you are changing the patient from using oral steroid to topical steroid. Before surgery, unless you don't operate, how will the topical steroid penetrate into the sinuses? So with surgery, you are giving access to the topical steroid to penetrate deep into the sinuses. And that's how the topical, once it reaches everywhere, so there's no need of oral steroid, you can say. So that is important, the histopathology in all these patients. And this is a very good proof. And so it saves you from medical legal problems as well again. Because you have a documented evidence of the patient's medical condition having high eosinophilia dictating the need of long-term steroid treatment.
And so what about the basement membrane? You said if the basement membrane is more thick, then again even that will require a long-term treatment.
Again, it dictates the process has been going on for long, which has already given fibrosis. It is the eosinophilic disease which results in fibrosis. What happens in asthma? Ultimately, the tracheobronchial mucosa becomes fibrosed. And that is the most severe aspect of the disease. If you have a severe basement thickening, that means patient has a severe disease. Patient may be having underlying bone involved, maybe having osteitis, and those are the patients who really need a long-term treatment as compared to the less disease profile patient.
Okay. How often you do preoperative biopsy? I mean, when you do, what's your indication to doing preoperative biopsy?
For simple polyps, never. Never. Yes, if you have some suspicion based on the radiology, yes, you can.
But in an adult with a unilateral polyp, will you consider biopsy before surgery?
Yeah, based on the radiology, boss. If my radiology is giving me some suspicion, the next session, probably on Sunday or any day when was described, we'll discuss in detail on radiology, how radiology is game changing. So your point is valid. In unilateral disease, one should be very careful. Because in unilateral disease, even if you see polyps on endoscopy, that polyp may be a pushed mucosa and behind could be a tumor. So in that situation, radiology is game changing. And then you have to take a biopsy. In that situation, if you ignore the radiological sign, then you cannot get an optimized situation.
Yeah, especially adult, for example, adult female, middle-aged with a unilateral polypoidal mass.
Yeah, male or female. Unilateral disease is always challenging.
Yeah, you have to take MRI probably to rule out inverted papilloma or other tumors, isn't it? Because especially if there is no history of allergic rhinitis. So would you do that pre-operatively, or
can you repeat your question, boss?
Suppose there's a female coming to you, a middle-aged female with a unilateral polypoidal mass on one side.
Yes.
What will be your approach to this patient? Because it cannot be, there's no history of allergy as well. So it could be an inverted papilloma, isn't it? So your management differs.
Yes.
So what you would like to do, a MRI or a CT scan? MRI, of course, you have a typical
That's important.
approach.
Yeah. Sometimes you miss this. The reason is, for sinusitis, we are supposed to get a non-contrast CT scan done. Now, if suppose patient has a tumor, in spite of having a CT scan, we can miss the tumor because of lack of contrast.
That's true.
In non-contrast CT scan, if you find unusual bone erosions, unusual expansion of the sinuses, that is the slightest suspicion which gives you to get MRI done.
Yes.
In a regular situation, no need. And many times, that's the reason. Many a times, these inverted papillomas and all these pathologies are diagnosed as a surprise finding intraoperatively. You take up a case for sinus surgery and it turns out to be a papilloma. Many times it has been diagnosed like this.
Yeah, but intraoperatively, many times you will not be able to distinguish between a polyp or
intraoperatively. Once you come across the tumor, it is different from the polyp. Then you can diagnose once you reach the tumor. Once you debride the tumor and debride the polyps and come across the tumor, you can easily identify them. But then the question would be, without a proper diagnosis of the papilloma, with a surprise diagnosis intraoperatively, your management is, your possibility of optimized management is poor. Because in that situation,
how do you intraoperatively distinguish or identify whether it's an inverted papilloma, for example?
Yeah, tumor is different from the polyp, as simple as that. I am not saying inverted papilloma, tumor.
Tumor, yeah.
Now, if you have to really identify which tumor it is, you can send for the frozen section. But in a situation when you get a surprise diagnosis of papilloma or any tumor, it is not possible to give an optimized treatment without having a proper radiology of the extension of the tumor beforehand, without knowing the actual bone erosion where the tumor has gone in. Because papilloma, suppose it is papilloma, they are notorious to recur. Unless you remove the underlying bone thoroughly, it is bound to come back.
Yes.
And that information, if you have a pre-op beforehand in your basket, you can do a proper treatment as required. But in surprise diagnosis, this is always a problem. This is how. This is not uncommon to have surprise diagnosis of papilloma and tumors like this. And the reason is only one, because for sinus surgery, we get only non-contrast CT scan.
Yes.
So before we move to this management, in the investigation part that we were talking, will you also include the aspirin sensitivity test?
Only in those patients who have polyps and asthma.
Okay.
Some test tried.
Yes. Okay. That is only for those patients.
Okay.
Patients not having asthma are not unnecessarily screened with the aspirin sensitivity.
Okay. So before we move on to the management, there are a few questions regarding this investigation. I'll just ask. Dr. Ravi Shankar from Muscat wants to know, do you recommend vitamin D estimation in all patients of CRS? If normal, then any need of supplementation, will it improve the steroid sensitivity?
Ravi boss, hello. Dear boss. Boss, Ravi is there. So, yes. Vitamin D supplementation, as I said, in those patients having extremely low levels, supplementation definitely improves the situation, improves the overall immunity. Vitamin D is one of the things which improve the immunity. Okay. So anything which improves the sinonasal immunity will have a positive impact. I said in the beginning about the bacteria. Antibiotics killing the inhabitant bacteria, commensals, will have a negative impact. That's why to avoid antibiotics unnecessarily, unless it is very specifically directed towards the pathogenic bacteria. Okay. Same is there.
Okay. And sir, Dr. Amit Kesri from Lucknow wants to know that the polyps which are non-eosinophilic and eosinophilic, the management, they are the same or they are different?
Yes, Amit, Surat abhi tak. So his question is valid. Polyps who are eosinophilic and non-eosinophilic, yes, there could be non-eosinophilic polyps. The management, see, the pre and post-operative management, as I said, it should be directed towards the pathophysiology. Now, if it is eosinophilic, will require long-term steroid irrigation. If it is non-eosinophilic, may not need. That's how the post-operative treatment to prevent recurrence. Our goal is to prevent recurrence. Will be directed against the pathophysiology. If it is eosinophilic, obviously will require long-term irrigations later on, the steroid irrigation, because steroid is the mainstay of treatment.
Okay. So Dr. Santosh from Latkar from Pune wants to know that any other investigation if you suspect a cystic fibrosis. If you suspect a cystic fibrosis, will you
fibrosis? Yes. See, cystic fibrosis is a genetic abnormality on the CFTR gene, cystic fibrosis conductor gene. So the investigation at the genetic level cannot be done in a routine clinical practice. So if you suspect the cystic fibrosis, the other investigation people get done is the nitrous oxide exhalation level. That will tell you exactly that an extremely low nitrous oxide means there could be cystic fibrosis. This is almost always in the children in the lower age with polyposis. And the aim of treatment, I tell you for cystic fibrosis to everyone, aim of treatment in cystic fibrosis is not only to improve the nasal condition. Aim of treatment is to prevent lung infection. Because the problem at the lung level is fatal. So the infection in the upper airway can lead to infection in the lower airway. So diagnosis is very important for the optimized treatment to save the child. I'll come to cystic fibrosis with a separate slide.
Okay, so Dr. Vinod Felix from Kerala wants to know when you do the allergy test and the desensitization in a nasal polyp patient, like pre-operatively, or when will you do an allergy test for patients?
Generally we do allergic test in a polypoidal patient once you have planned surgery. Generally we do post-operatively.
Okay.
Because it doesn't affect the treatment, because per-operatively, peri-operatively, post-operatively, patient is always with a steroid cover, with the irrigation or whatsoever, so allergy doesn't exaggerate. After the healing has taken place, you can get the skin prick testing and direct the treatment later on. It is not a sort of something which is essential to do pre-operatively.
That will
one point. Hello. Yes, one question from Dr. Kusum Patidar. She wants any difference in the investigation in pediatric polyposis or adult polyposis. Or suppose a pediatric polyposis case comes, any specific extra investigation you would prefer?
Yes, that's a valid question from Kusum madam. So, pediatric polyposis is a different entity and a different management. I have a separate section today on the pediatric sinusitis. The reason is, in pediatric sinusitis, your sinus surgery is never a preferred treatment option. As I said, the role of sinus surgery is to give access to the topical irrigation. In children, you can't expect that much of cooperation post-operatively for the regular douching. Similarly, in children, the sinus surgery is not all that easy as compared to the adult. The chances of complications are more. So, in children, it has been found that majority of this sinusitis, which is not responding to the medical treatment, adenoid is the main site of problem. Harboring biofilms, releasing bacteria, giving sinusitis. This has been proven now, and in that the preferred treatment is adenoid. We will always, in children, assess for the adenoids. Children with bilateral polyps, you must rule out cystic fibrosis. Children with non-polypoidal sinusitis not responding to medical management, rule out adenoids. This is the difference. Another investigation which we add on, which I have made a separate slide later on, is immunodeficiency. up to 10% of the patients, this is another, we have seen our own patients, our own mistakes, I'm telling you, up to 10% of the patients have some systemic immunodeficiency. This disease, as I told you, is related to the sinonasal immunity, as we have seen in the past slides. Anything which improves the immunity will have a positive impact. If the patient has a systemic immunodeficiency and you are trying to treat sinusitis with surgery, how can you expect a good outcome? So, if the patient has a systemic immunodeficiency, we need to rule out. Otherwise, how many times you operate, whatever treatment you give, is never going to work. So, in up to 10% of the patients are suffering from immunodeficiency. That could be primary, secondary due to HIV, diabetes, whatever. Primary due to ciliary dyskinesia, hypogammaglobulinemia. Many of our patients, we have discovered this immunoglobulin deficiency, which we have referred to the immunologist for the further treatment. And how you can pick up those patients, that is important. Patients who are so refractory to treatment, in spite of all your antibiotics, steroids, everything, in spite of a good surgery done, coming back with a severe infection post-operatively. That is something surprising, are the patients where you need to investigate for immunodeficiency. Refractory patients, recurrent patients, recurrent patients, and patients having recurrent purulent low respiratory infections. Any patient with sinusitis developing recurrent low respiratory infection, you must rule out immunodeficiency. So up to 10% of the patients are having some or other sort of immunodeficiency which need to be ruled out to get an optimal treatment. That is important. I told you, this is like a syndrome. The goal is to prevent recurrences. And in order to get that, we need to rule out everything. It's not that you see a patient with polyp and operate tomorrow. It's never going to work. I mean, not always going to work.
Okay. What is the role of antihistamines in a case of acute and chronic sinusitis?
Sinusitis, antihistamine has zero role. Antihistamine has a role in controlling symptoms of allergic rhinitis.
That's true.
What does antihistamine do? It blocks the histamine receptor competitively. So it has a value in preventing the effect of histamine which is released in the bloodstream after the allergic reaction. So once allergic reaction has taken place, histamine is released. Histamine is going to give symptoms after attaching to the receptor. And this antihistamine competitively blocks the receptor to prevent the symptoms of histamine. It has nothing to do with sinusitis.
But as a temporary treatment, initial treatment, we do have to give that, isn't it?
It has a detrimental effect, rather, I would say. In sinusitis pure, it can have a symptomatic relief in allergic rhinitis that may be concomitant allergy going on to the patient. Yes. But in sinusitis, it has a detrimental effect on the viscosity of the secretion. So it is not advisable to add on antihistamines to the sinusitis patient because it will impair the mucociliary activity further.
But now, when a patient comes to you with acute sinusitis, how do you manage in the outpatient? Because antibiotic also, you said a while ago that it destroys, kills the normal.
Acute sinusitis, yes. Acute sinusitis is a different entity. I was talking about the chronic sinusitis.
Acute on chronic sinusitis, that's what I'm talking about.
Acute exaggeration or acute sinusitis is mostly viral with superadded bacterial infection.
Okay.
That's a different subject altogether. Yes. And in that situation, the antibiotics do have a role. The main role is saline irrigation and antibiotics and any immunomodulator to improve the immunity overall. So acute exaggeration do need antibiotics. There is no question about it because that is mostly having superadded bacterial infection on viral initiation. It is always initiated by the virus with superadded bacterial infection.
So what do you mean? Proper irrigation, washing, and then that should work, isn't it? Yes. And you should delay antihistamines, antibiotics as much as possible.
Antihistamines have hardly any role in sinusitis, whatsoever, acute or chronic.
Yes.
And saline irrigation has a huge role. That is seen in this slide. Saline irrigation has a big role in the sense it improves the mucociliary clearance.
Yes.
Out of all medical management options besides the steroid, the next role is saline irrigation. It removes all pathologic things in the nasal cavity, maybe bacteria, antigen, whatsoever. It removes the thick mucus, crusting, everything. It improves the sol layer of the mucus. It improves the quality of the mucus. So overall, it improves the mucociliary activities which is required in the management of sinusitis.
Dr. Satish, this presentation is also going on YouTube all over the world, and thousands of people are seeing it. One question is there. So I think you use lots of doxycycline and macrolides in your clinical practice and post-op cases. Have you encountered any complications like enterocolitis or anything in your practice?
Before complications,
That's a very good question. I tell you.
Sir, before complications, you first tell us more in detail about the dosage of doxycycline and macrolide. Which one do you use? What is the dose of it?
And then next slide is doxycycline only.
Okay.
But yes, since this question has come, doxycycline is used for medical management in the appropriate medical management before any surgery is required for the polypoidal disease. And the dosage is, and this is used for 21 days, 100 milligram BD. And in adults with these doses, we have hardly encountered any complications. Regarding macrolides to be used for months. And we never give macrolides to any patient above 50 years for our safety and patient safety. And on patients who are taking other medications for systemic diseases. Patients on statins, patients on cardiac drugs, patients on XYZ things, macrolides can have interactions. Any cardiac patient, macrolide is strongly contraindicated because it may increase QT interval.
Yes.
Any liver and kidney patient, macrolide is contraindicated for long term. For young patient, it's amazing. And I tell you, in the medical management, we call macrolide a wonder drug. I tell you the reasons. I will see in the coming sections the biofilms. The drug which act or prevent biofilm formation is macrolide.
Macrolides. For
immunodeficiencies, the antibiotic of choice is macrolide because it has an immunomodulatory effect. Post-operatively to prevent neutrophilic infection and all this, because macrolides inhibit the neutrophilic activity. Macrolides is the choice. So everywhere the befitting drug is macrolide, but we have to be cautious in using elderly patients, patient with systemic diseases like liver, kidney and cardiac, or patient is on any medications like statins, obese patients, we should avoid. Otherwise, it is very safe.
So doxycycline basically works at the eosinophilic level, right? And macrolides work at the neutrophilic level.
Yes. Where this question come from? Who asked this?
Sir, I am telling you.
No, Dr. Jishan from Lucknow through YouTube.
Oh, great. Good question.
What's the dose? 250 daily. You don't give the full dose, isn't it? For 3 months you give post-operative.
Yes, because you have to use for long term. Yeah, people have compared the high dose and low dose studies, but for the long term use, it is safer to use a low dose because our role is not antibiotic, the role is immunomodulation.
So, in which patients do you advise macrolides for long term?
Non-polypoidal. I have a slide coming, boss. Next slide is macrolides.
Okay.
And coming to these treatments.
Okay.
So, why I have put this slide here now before starting the management part? Because this is most important slide to understand the role of surgery. This present slide. Because in the present scenario, as I said, at all level of cascade of events in sinusitis, right from the epithelial level to the cytokines, the only thing works is steroids.
Yes.
Okay. In pre-operative setting, in the medical part, You give oral steroids are most effective, but we cannot give for long. So what we can give now? Topical steroids. Now, if patient has a severe inflammatory load with lot of polypoidal mucosa everywhere, topical steroids would find inadequate. Okay? And in that case, either you give oral steroid or you do sinus surgery and give penetration to the topical steroid. Got my point? Why I am saying this? In the present context, the only option is steroid. And if you have disease load, inflammatory load is too much to be taken by topical steroid, you have no option but to operate on that patient to make him acceptable for the topical steroid. You cannot give oral steroid for long.
Can I interrupt you? In cases of polyposis, for example, if you give a heavy dose of oral steroid,
yes,
followed by topical, can we avoid surgery?
Yes. So this is the strategy. This is a part of management. That's why this slide, I have put the first thing, the most effective is the topical and the oral steroid along, but you cannot use for long term. So what do people do? They go a 5 to 10 days course of oral steroid and follow with the topical. Okay? If the inflammatory load is not that much, can be tackled with a topical, those patients do not need surgery. And inflammatory load is too much to be tackled by the topical steroid, requiring the need of the oral steroid again, are the patient where surgery is indicated. Got my point?
Yes, yes.
So you can, otherwise I will tell it the other way around. Any patient requiring oral steroids again and again to control their symptoms are the candidates for sinus surgery.
But the frequency wherein you put a line as to...
Yes. So any patient requiring more than twice the need of oral steroid in 3 months' time is a straight away candidate for sinus surgery.
That's a great point.
This is the standard way in the Western country the sinus surgery indications have been redefined.
Yes.
So suppose I am going by your way, like you said, you start with oral steroid, 5 to 10 days, put the patient on topical. If he is doing well, you don't need to operate.
That's what.
Now, if the inflammatory load is too much to be taken by topical, he will again develop symptom and need oral steroid. And those are the patients which require surgery, so you can avoid the need of oral steroids in the future. I hope you got my point. This is what this slide is saying, what I'm trying to say through this slide.
So basically, surgery is taking away the inflammatory load, as well as giving a pathway for your oral steroids.
See the middle aspect of this slide, what I've given. Yes. What the surgery is going to give us.
Yes.
Establish ventilation drainage, reduce the inflammatory load, and to provide access to the topical. I hope you got my point.
Right.
So that's why in the definition, I said in the beginning, it is all clear to everyone. Those sinusitis patients where the appropriate medical management fails, the surgery is indicated.
Yeah, that's true.
What is that appropriate medical management? Why it fails? Because of the inflammatory load. If the inflammatory load is too much to be tackled by the appropriate medical management, and that appropriate medical management is centered on only one thing, topical steroids. That is safest. That is not oral steroids. You can give topical steroids for longer period because they are safe. But if that load is not managed by the topical steroid alone, you have to operate to reduce the inflammatory load. That is how the indications of surgery are redefined. I hope you got my point, what I'm trying to say.
Yes, sir. So since you're talking about this,
this slide shows when to operate and why. When to operate and why.
Okay, so since you're talking about this, can you tell us which topical steroid do you use? There are many questions they want to know about.
So in a pre-operative setting, what topical steroid can use is the only weapon you have is nasal sprays. Because you cannot do douching with a topical steroid as the sinuses are closed. So the only option you are left with is the nasal sprays. The fluticasone, mometasone is more potent. whatever. So in the pre-operative setting, what you can give patient, the normal saline irrigation and topical steroids. If the load is not very much, a topical steroid can take care of it. There is no need of surgery. If intravenous load is too much to be taken by topical steroid, then is the role of second thing, that is space. The second part in the middle of this slide. And that will serve the purpose of avoiding the need of oral steroid in the future. Because now it gives penetration of topical steroid deep into the sinuses. Okay? And in the future, in the third part of this slide, targeted therapy. That is underway. That is the future. Because in the present context, the only weapon we have is the steroid. And in future, when the targeted therapy is established, that is going to take over everything. That is going to take over the steroid. That is going to take over the sinus surgery. Because that is right attacking on the pathophysiology of the disease at a particular level. I hope it is very clear.
Yes. Is there any particular weeks that you want to give? Like for 8 weeks maximum you can give, or 4 weeks? Is there anything?
Yeah, it depends. See, generally they give 8 to 12 weeks a trial. Okay. Now, see, this is a gray zone that we have to take a call, depending on your experience. Suppose you have a massive polypoidal disease. In 3 weeks' time, 4 weeks' time, there is no response coming. Patient is needing oral steroid. Why to wait for 12 weeks? So in a very clear-cut situation, you don't need to. That's why I said it's a gray zone. But yes, in the borderline cases, who are responders, who have a good immunity, who have a good vitamin D level, they may respond well, and then you can go on for 8, 12 weeks before taking a call of surgery. So it's always a trade-off between medical and surgical treatment. And you have to take a call on based on your all these factors in your experience.
Dr. Satish, there are so many questions on pre-operative role of any mucolytics or antifungal. These are 2 points.
I have a slide, 0. All 0.
Yeah.
Only thing which has a role is a steroid, saline, and third thing which has an impact on improving immunity. That's why I see in the bottom of this slide, immunomodulators.
Yeah, future of the surgery.
Anything which improves the immunity has a positive impact. That you have to. That includes vitamin D. That includes probiotics. That includes prebiotics. That includes bacterial lygates. Anything which improves the immunity will have a positive impact.
So Dr. Prakash Monka wants to know that is there any preoperative role of azolastin along with the steroids? Is this combination? Is there any role of this combination?
First of all, convey my regards to sir. Thanks for being with us. Azolastin is an antihistamine. We have already discussed antihistamine has a selective role of competitively binding to the histamine receptor for not allowing the histamine to give symptoms. Now, once we are talking of sinusitis, antihistamine has no role. But yes, in those patients, sinusitis patients who have, along with concomitant allergic rhinitis also, azolastin and this thing, fluticasone combination can work well. So in known patients with a concomitant allergic rhinitis is a good viable option rather than giving oral antihistamine. Sometimes if it works.
The previous question Parminder had asked was the steroid what we give, you give post-operatively, the solution, the steroid.
The budesonide.
Yeah, budesonide.
Yeah. That will come later on in the post-operative management, boss. But yes, you are right. Budesonide is the preferred because of its aqueous solution.
Yes.
Okay. So Dr. Deepak Dalmia wants to know that injecting triamcinolone, is there any role for nasal polyps?
Deepak Dalmia. Hi Deepak. So triamcinolone is what? A steroid. So you are trying to give steroid in one or other form is the same thing. See, injecting, giving a high local dose can work to some extent in that region. but that is not long lasting. It is not a simple single polypoidal disease. It is a diffuse disease. See, eosinophilic disease is a diffuse disease. You have to target the entire sinonasal system. Targeting one polyp, injecting triamcinolone will work on that particular polyp definitely. No doubt about it, because it is steroid. Steroid is steroid, giving in any form. But in overall management, it will be too inadequate.
Have you tried colloidal
spray?
Yes, or biofilms. I'll come to it, boss. In the comorbidities, it has a role in the biofilm management. We are using
Dr. Satish, one question from Dr. Himanshul Kala.
Yes.
Preoperatively, you give immunotherapy by sublingual or subcutaneous by any route. You give immunotherapy in your pre-op cases.
Pre-operative or post-operative, there's nothing like that. The patient has a concomitant allergic rhinitis. For allergic rhinitis, the only treatment which can change the natural course of disease is immunotherapy. And I learned this subject from my dear friend Ashin Desai a lot. Like you said, the Vikram Khanna is doing a lot of allergy work. So they can guide you better. But immunotherapy has a role in treatment of allergic rhinitis. You are giving pre-operatively, post-operatively, that is different. It has nothing to do with the management of sinusitis. It has a role on sinusitis because you are treating a comorbidity which has an impact on an overall outcome, positive impact on the overall outcome.
Okay, so Dr. KKAZ and Dr. Neeraj from Nepal, they want to know what kind of, is it an isotonic, hypotonic or hypertonic saline that you would say?
Yes, saline, saline irrigation, as I said, is a #1 treatment after the steroids. And saline has a positive impact. Now, saline, a lot of studies have been done on the hypertonic saline. It works better on the thick mucus. Like in cystic fibrosis, where the problem is the viscid secretions, or preferred treatment, saline is a hypertonic saline. In usual conditions, we do not use hypertonic saline. The third thing, the recent addition now, and we are switching more and more towards the ringer lactate. It has been proven now, this is pure evidence-based material, ringer lactate should be the preferred solution rather than saline. Ringer lactate is more physiological than saline. It contains potassium and lactates, and it is more physiological to the mucosa. So we have now switched over to the ringer lactate intraoperatively as well, and preoperative, postoperative irrigation rather than saline. Still we are using the word saline because it's a common which we use. But in practical practice, we have started using ringer lactate, which is much better than all this. In regular practice, when you are using saline, hypertonic saline, we try to avoid for this. The reason is hypertonic saline has a irritation sometimes for the patients on the mucosa. It lot of papers saying having negative impact on the ciliary activity by hypertonic saline. Why to fall into that controversy and give problem? So best is to use ringer lactate now. Yes, hypertonic saline in certain situations like cystic fibrosis is the choice of material. Hypertonic saline.
Okay. Okay, sir. Sir, I think we can move ahead with your few further slides and then we can again come back to the questions.
Okay. So the next is what we are thinking is appropriate medical therapy. Every time we're using this word appropriate medical therapy. If this doesn't work, then surgery. So this slide is just an overview what appropriate medical therapy can work. Boss was asking, the theory was whether the mucolytic, antifungal, see nothing works, only these things work. For polypoidal disease, obviously for both saline and topical steroid are the mainstay of treatment. For polypoidal, you can give oral corticosteroid like George Boss said, for time being, short courses, but it has no role in the non-polypoidal necessarily, because that is not eosinophilic predominant disease. For polypoidal disease, the oral antibiotic, if there is obvious infection, culture directed, otherwise, as I said, doxycycline. And there is some publication, there are certain publications showing a positive impact of Montelukast on the polypoidal disease, though we are not using it. But in a non-polypoidal, the thing which works is either the culture-directed antibiotics or the macrolides. This is what we have discussed so far. So this is a summary. This is a summary what works. Now, what is not there in the slide, that means that doesn't work. As simple as that. These are the only thing which works. Besides that, there is no role of antifungal at all. This is a big myth using antifungal in the management of any sinusitis. Maybe fungal sinusitis, unless it is invasive.
Invasive.
Yes.
Antifungals have only role in invasive sinusitis. Otherwise, no role, no meta-analysis has proven so far. Fungus, the fungus is ubiquitous. Yep. In our normal breathing, we inhale fungus a lot every day. But our immune system is able to tackle it. Our mucociliary activity is able to handle it and trap the fungus and direct towards the gut. And it doesn't give problem. Fungus can only give problem is if our mucociliary activity is at fault. See, by and large, there are 3 types of fungal infection. Number 1 is a mycetoma, fungal ball. Fungal ball is what? The fungus which we are exposed to in the nasal cavity, because of the stasis, the lack of mucociliary activity gets trapped. And then the collection of fungus given to fungal ball in any of the sinuses where it is trapped. And mostly it is only a single sinus affected. Second variety in a non-invasive fungus is allergic fungal sinusitis. That is in an immunocompetent patient because of hyperreactivity to the fungus. Allergic reaction to the fungus where the eosinophils are reacting. Body is reacting to the fungus leading to the situation of AFRS. That is body's reaction, hyperactivity. And third is hypoactivity, immune suppression. An immunosuppressed individual where the fungus invades. So there are basically 3 types of fungal invasion, and only in the third type, the antifungals have a role. Otherwise, antifungals, big no. Okay? There is certain role. Big no means not 100%. I have a separate slide to show you the place of antifungals. Besides invasive fungal sinusitis, that I will come to. So now, as we said, the topical and the systemic steroids. Steroids, we all know, as I told you, it works at every level of immune cascade. It improves the endomicrobial protein. It works at every level of cytokines. And in the preferred ones among the topical are the fluticasone and mometazone. Mometazone is most potent, has less systemic bioavailability, less than 1%. So this is our preferred one, mometazone, as compared to the fluticasone. And the only limitation is they do not cross beyond the anterior third of the nasal cavity. What does it mean? So in a case, suppose you have done a sinus surgery. Post-operatively giving penetration now to the topical steroids. Now there is no role of these nasal sprays because they do not penetrate beyond anterior 1/3 of the nasal cavity. So in any post-operative situation after sinus surgery, there should be no question regarding the use of topical nasal sprays, because now the sinus surgery has switched over to a different scenario where it has given access to the topical steroids, and then irrigation has a role which can penetrate deeper rather than the nasal spray.
Dr. Satish,
yes,
Dr. Satish, I think so many questions. So many people are asking, why there is steam inhalation in preoperative as well as postoperative? They get a very good advantage. Is any
steam inhalation has a psychological advantage, maybe some advantage or decongestion of the mucosa.
They use lots of these medicines.
There are so many adjuvant therapies. There is no harm in doing steam inhalation. It humidifies, it improves the congestion. It may have some positive impact, no doubt about it, but hardly any place as far as a definitive.
There's a mucolytic action.
Pardon, sir?
It might soften the mucus secretion.
Yes, it may soften. Yes. It may have a positive impact. I don't deny.
Okay.
Now, this slide is to show the role of systemic steroids. Number 1, as George was said, the short-term management in polypoidal disease. Number two, preoperatively to improve the surgical field by means of reducing inflammation. If you reduce the inflammation, the intraoperative bleeding is comparatively less. And third is post-operatively in terms of inflammatory state. When there is inflammatory state in the post-operative period, it improves the post-operative outcome when you give a short course of steroid post-operatively. So this is the only three indications where the oral steroid is used. Rest is topical, preoperative topical in form of nasal sprays, post-operative topical in forms of irrigation. And these are the three indications for oral use of steroids. Okay. Now, your question, doxycycline. As I said, already mentioned, we give for a short course 3 weeks, preoperative setting in polypoidal disease. And this is antibacterial. We all know Staph aureus is the most common bacteria implicated. A lot of people have implicated Staph aureus in the etiology of development of sinusitis by means of inducing superantigens, and doxycycline has activity against Staph aureus as an antibacterial. But this is not used for that. This is used for its anti-inflammatory effect. See the vast anti-inflammatory effects at the molecular level with doxycycline. It is, and that's why this is used, preferred for the polypoidal disease. And for the macrolides, like Dr. George Worski asked, macrolide is a wonder drug, I tell you, for sinusitis. A number of applications where only thing works is a macrolide. That's why it is a wonder drug. See, the only antibiotic which has a significant intracellular accumulation is the macrolide. And you know, there are a lot of publications with the Staph aureus showing intracellular accumulation. And that goes in a different phase to be attacked by any antibiotic and becomes virulent. And it is where the macrolides can work. I told you in biofilms, macrolide works to prevent biofilms. In immunodeficiency syndromes, conditions, anywhere, by means of immunomodulatory effect, macrolide is a drug of choice. So it, by means of activity on the neutrophilic action, it is preferred in the non-polypoidal sinusitis. Indications, as we have already discussed, if the serum IgE is low or normal, then it should have a role. Otherwise, no use. If the patient is severely allergic, high IgE, there is no role. In patients who have a polypoidal disease, this is one thing very surprising. I investigated in the literature. In patients who have a polypoidal disease, not responsive to steroid at all, you can think of giving macrolides, and they do work. Okay. So macrolide is a wonder drug. I don't know how they work everywhere, but this is something where nothing works. Macrolides are the preferred things. Now, as I said, this is not a simple disease. It's like a syndrome. To get the optimized outcomes, we need to treat the comorbidities. Like Dr. Vikram Khanna asked in the beginning about the allergy. If you don't treat the allergy, patient will have similar overlapping symptom post-operatively and will never be happy with the treatment. And will come back again with the same similar symptoms. So all these comorbidities have a significant impact on the overall outcome, which I have mentioned here. That's why I mentioned here. So if you take this one by one, you'll find something important. So allergy, as we have already discussed, this is mostly in the polypoidal disease, a concomitant allergic rhinitis you will observe. And treatment we all know, immunotherapy and all, but all those patients who are allergic, they always remain in a pro-inflammatory state. See, allergy, edema, impaired mucociliary clearance, all these are pro-inflammatory state, and in a sinusitis patient, it predisposes to the aggravate, it may aggravate the sinusitis. That's why it is important. It is something, not that allergy has nothing to do with sinusitis. Allergy is giving pro-inflammatory state. It is giving edema to the mucosa, which can block the sinus and can induce sinusitis as well. So particularly when there are anatomical abnormalities which can predispose to a sinusitis patient, suppose, who is allergic rhinitis, has a concha bullosa as an anatomical abnormality which has already compromised the middle meatus, has a significant DNS which has already compromised the middle meatus, and patient has a severe allergic rhinitis, it can predispose to sinusitis easily because you are having allergy in a compromised sinus situation. Compromised situation which can predispose to sinusitis, and on that allergy can predispose actually. So it is important to understand, so that concomitant treatment of allergy is very important.
Yeah, best.
Second thing, yes? You're saying something?
No, sir.
No.
So this slide is most important. I tell you, if you focus on this slide, you can improve your sinus surgery practice 50%. Only understanding the value of this slide. Everybody.
Yes.
All the asthma patients, I told you earlier, I'll tell you the reason how you can improve your sinusitis practice 50%. It is a unified airway concept which has been very well accepted. The upper airway and lower airway is same airway. Sinusitis is the asthma of upper airway. And it has been proven up to 60% of the asthma patients have associated sinusitis. Try to understand what I'm trying to say. Up to 60% of the asthma patients have sinusitis. And if you treat the sinusitis, the need for the further asthma treatment can be significantly reduced. What's my point? A patient who is having severe asthma, being treated by the pulmonologist, who can never look at the sinusitis at all, he will keep on giving asthma treatment. He'll keep on giving steroid inhalers. He'll keep on giving oral steroids in between. According to the symptomatology, he will keep on increasing the doses, ignoring the concomitant sinusitis part. If that concomitant sinusitis part is taken care of, the need for the asthma treatment can be significantly reduced up to 90%. It has been proven by hundreds of publications. In those asthma patients having concomitant sinusitis, if you do a sinus surgery, treat the sinusitis, keep the patient on topical steroid irrigation, the need for the asthma treatment can be significantly reduced. Why I am saying, what is the value of this? We need to have a collaboration with the pulmonologist.
Yeah.
We need to have a collaboration. We should be able to convince them to improve their practice. All these asthma patients going to the pulmonologist should have a sinus checkup by an otolaryngologist. That is the bottom line. And for that, we should be able to convince our pulmonologist for the betterment of the patient, because of the lack of collaboration between these two specialties. The reason is their interest. Pulmonologists will never refer an asthma patient to ENT to look for the sinuses. Can you find this practical? Never. And those poor patients are being treated with more and more steroids because their sinus disease is always ignored. So we must collaborate with the pulmonologist in our vicinity, whoever is working wherever. We must convince them, presenting them evidence, treat some patients for them to convince them. And once they find that the asthma improves so drastically with the upper airway management, the sinusitis management, the sinusitis practice will go up, shoot up. That's why I said, yes, you can improve, because majority of the sinusitis patients are being treated by the physician and here pulmonologist, because for the patient, asthma is a priority, not the nose. And whatever steroid inhalation, oral steroids they are giving, getting benefit in the sinusitis part also. So they will never approach on priority to the ENT surgeon. Their priority is asthma. And the pulmonologist will never look at the sinuses. That is so pity. So this is, the onus is on us. Onus is on us to collaborate with the pulmonologist, to counsel them, to convince them that all those asthma patients, they should refer for a consultation. Any question on that?
Yeah, we say it is in fact bilateral. Even suppose we do very good surgery, we have to send them for the chest physician's opinion also. If preoperatively also, even postoperatively, same thing. They should also adopt it. So we should take a regular conversation or classes with them.
That's why I said you must collaborate.
That's a very valid point.
On the other side, all those patients you are operating for sinusitis having asthma, means you can assume that the patient has a high inflammatory load. Their overall outcome is not as good as patient without asthma. They need to be more, frequently visited post-operatively. They need more thorough steroid irrigations. They need more treatment post-operatively overall as compared to the non-asthmatic patients. For that, we have to counsel the patients who are having asthma. Patient coming to you for sinus surgery with asthma, you have to counsel you have a severe disease. And you will need a lifetime surveillance overall. There are certain group of patients where you have to have a thorough surveillance for longer period. Like for example, young patient for sinus surgery, patient with asthma, patient with allergy, those are the patients that when you operate on those patients, you have to tell in the first end that you'll need probably lifetime surveillance for your sinus management. Those are not easy patients to treat with. If you do sinus surgery and forget, they are bound to come back to you, to fall upon you, your surgery has gone failure. So the onus is on us to tell them that what condition you are having.
Okay.
Okay?
Yes, sir.
This is another important factor. Again, to give optimized result, the onus is on surgeon. And to involve the patient is our duty. This is something found as a strong association between smoking and the overall outcome. Because what we are banking on to improve the nasal immunity, and smoking is one thing which has a detrimental effect on the overall nasal immunity. You can see the reasons mentioned in the slide. The microbial flora, the commensal flora, which is important, smoking has a negative impact. Ciliary activity, smoking has a negative impact. The vitamin D, which is converted into the active form by alpha hydroxylase in the nasal cavity, this smoking has a negative impact on that.
Okay.
See how important it is. Okay. It induces biofilm. So many things. Smoking, you must, all those patients who are asking questions, doctor, will I need the surgery again? Yes. If you don't want, you have to quit smoking.
Okay.
He will never blame you. Okay. You have to tell him you have to quit smoking now and forever if you really want to have good sinus surgery result. And this is the fact. Okay. You have to be sometime harsh on the patient on these issues once it is so obvious.
Yes. Sir, about the asthma, Dr. Shruti Bansal from Mumbai wants to know that do we need to look for the signs of sinusitis in pediatric asthma patients?
Yes. Yes. Younger patients, I told you, are worse. In overall outcome, younger patients have a poorer outcome. So, at pediatric patients with asthma have a severe inflammatory profile. So we have to be very cautious.
Okay.
So smoking is something, it is so important, but it's so easily neglected by the doctor and the patient as well. This should be in our consent form about the smoking, and we should positively convince our patient to quit smoking. Otherwise, in spite of having done a good sinus surgery, you may not experience a good outcome. So on the part of the surgeon, the deficiency is always considered on the part of the surgeon. This slide is again very important. Up to 5 to 10%, and this is a real figure. You take up any study in the world, and this is almost always neglected. Almost always neglected, immunodeficiency. And imagine a patient having immunodeficiency and you are treating an immune disorder. Sinusitis is an immune disorder. How can you expect a good outcome? So all these patients, transplantees, HIV, diabetes, you have to be extra cautious. All patients with recurrent purulent infections, all patients with needing more severe treatment again and again, refractory, recurrence, repeated recurrence, you must rule out immunodeficiency. And we have been able to pick up a couple of patients by immune testing, and ultimately we refer to immunologists for the further treatment. But yes, serum immunoglobulin is one thing you can get done on your end to refer that patient to the immunologist. And that is something, a treatable situation, and immunoglobulin therapy works very well, which is to be done by the immunologist. But our duty is to rule out this situation. And in these patients who are liable to get infection again and again, along with the culture-directed antibiotics, macrolides have a big role. This is how the wonder drug macrolide works here again.
So which macrolide do you give in your practice maximum?
Clarithromycin, mostly clarithromycin.
And the dosage will be how much?
250 milligram a day,
okay.
Not the antibiotic dose, lesser dose for longer period, 3 to 4 months.
Okay.
And it works.
Okay.
Is any association with the hepatitis B, C, or liver cirrhosis with the incidence of sinusitis or CRS cases?
Not really. Those are somehow, by some other means, are immunodeficient patients.
Yeah.
Those are not good candidates for sinus surgery. These sinus surgery cases, once you're taking up a case for sinus surgery, you have to rule out all these things.
Yeah.
Because macrolide clarithromycin do you give? When do you decide to give? Which patients do you give?
Those patients with non-polypoidal sinusitis, with low or normal serum IgE are the ideal candidates for macrolides.
Okay.
Sir, Dr. Pulkit from Ratlam wants to know that if the patient smokes, and can we tell the patient to stop smoking before surgery, and if yes, then before how many days before? Is it something that we can do?
Yeah, it should be ideally stopped a month before surgery.
Okay.
To get back to the normal mucociliary clearance, ideally, in the ideal. But whatsoever it is, if it is stopped before surgery, it is always good.
Okay. Sir, what is the importance of Montelukast in the case of sinusitis with asthma? From Peshawar, there's a question by Dr. Riaz from Peshawar.
Hello, sir. This is our dear friend. So it's a good question. So see, so far in our discussion, whatever we have discussed, we never mentioned Montelukast at all.
Yeah.
The reason is Montelukast has a limited role, which we are coming to in the next few slides, in the AERD, aspirin exaggerated respiratory disease, which is leukotriene-driven disease. And there only the Montelukast has a role. Otherwise, Montelukast has no role in sinusitis at all. In some studies, Montelukast has been given in the appropriate medical management before surgery for polypoidal patients. But that is not widely accepted. The only role of Montelukast is in AERD, aspirin exaggerated respiratory disease. That Montelukast is one of the wonder drug in that situation. I'll come to that in the next few slides.
Okay. So one more thing is Dr. Paresh Nayak from Birmingham wants to know that in case of Samsters and resistant nasal sinusitis with polyposis, what is the earliest age that we can operate on a child?
So in case of, I missed that word.
So in case of resistant nasal sinusitis with polyposis or with asthma, or with the
Yeah.
Samter stride, what is the earliest age that we can operate on a child?
Age is no bar in that situation. See, that is a different endotype once it is a Samter stride. And we have to target the underlying pathophysiology. I am coming to that in next few slides. Underlying pathophysiology is a COX-1 inhibitor hypersensitivity. And we have to treat that, otherwise no treatment is going to work. And I tell you, out of all endotypes of sinusitis, out of all variety of sinusitis, the most severe form of sinusitis is AERD, Samter stride. Most severe. That gives the highest level of eosinophilia. That gives the highest level of resistant disease. And we have done hundreds of such cases. And now I can pick up, if you put an endoscope, when you start sinus surgery, looking at the condition of the hypoplastic mucosa, I can tell this is AERD. It's so obvious.
Okay.
AERD is such a significant disease and it is so easily being ignored. How can you expect outcome in a AERD if you don't desensitize a patient? That cannot work. That's how sinus surgery got a bad name in the beginning, that the patient needs revision surgery again and again. So that's why the value of this today's presentation to understand the underlying pathology. Every sinusitis is not same. Every sinusitis, we have to find something. You should not miss something before taking up the case for surgery, because once you operate, the entire onus is upon you. All faults lying with the surgeon by default. Now, this slide, as boss asked in the beginning about the biofilms, this is something which is a challenging situation for surgeons. Difficult to diagnose, difficult to treat, both ways. And the challenge is so much that whatever good work, surgery, medical treatment you have done is all gone if the biofilms are not managed. So for the audience, what is biofilms? Biofilm is just the aggregates of bacteria, the colonies of bacteria, simple colonies of bacteria encased in a proteoglycan matrix. And they are attached to the surface in the nasal cavities, sinuses. And that proteoglycan matrix protects the bacteria from the immune system of the host as well as antibiotics. So the bacteria survives in a different phenotypic change in that matrix and keep on releasing virulent bacteria in between. Keep on releasing virulent bacteria in between and no antibiotic works. Immune system doesn't work. So that is the most difficult situation. If you have operated on the patient and patient has a biofilm, whatsoever culture directed antibiotics you give, they hardly work. So that is something need to be discussed, and that happens mostly in the immunodeficiency situation. If some patient has a repeated infection, you are getting cultures, then giving culture directed antibiotics, you have to rule out immunodeficiency. At the same time, you have to rule out biofilms as well. Because now once you have a suspicion of biofilms, you have to work differently. You have to work in a different line to treat that patient. So, and mostly these virulent biofilms either are from the Staph aureus or Pseudomonas. Those are most difficult, most resistant, most recalcitrant to treat with. Now, as far as the diagnosis is concerned, there is no simple test to diagnose biofilm. In an ideal way, to diagnose biofilm, you need to have a confocal laser microscopy or FISH method, in situ hybridization, which is not clinically possible in a clinical setting, regular setting. So how do we diagnose? What do we do? In certain situations, we take a mucosal biopsy and get a gram staining done. You'll find the bacterial colonies. Now, you can find there is biofilm, but you cannot distinguish whether it is a Staph or Pseudomonas. In that situation, once you have done a gram staining and confirm biofilm, get repeated cultures done, because it keeps on releasing virulent bacteria in between, and some or other time you'll be able to catch in culture studies. If you find a Staph, then the treatment is different. If you find a Pseudomonas, then treatment is different. I'll show in the next slide. But this is how a practical way to diagnose biofilm. Otherwise, you cannot use a confocal laser microscopy or FISH method in a regular setting. What's my point? And there are a lot of immunological mechanisms leading to biofilm formation.
Sir, in your practice, which is the maximum that you've seen, which is the maximum organism that you've seen causing biofilm?
Staph aureus.
Okay. Dr. Satish, one friend of our Dr. John Shadow from Australia, I think he was supposed to come this time also. He was asking, what is the with the biofilm, can we flush the nasal cavity pre-operatively? Any with the Manuka honey like that?
Yes. Pre or post-operatively, Manuka honey is one of the most lethal treatment to the biofilm. Most, I would say, effective treatment against biofilm. I'm coming in the next slide on that.
He's from Australia, that's why he's asking. New Zealand is near to him.
His question is valid. His thinking is valid. So, what I have written in the end, macrolides, I tell you again, is a wonder drug.
Yeah.
The reason is macrolide prevents biofilm formation. That's why in the immunodeficient people, I mentioned in the last slide, macrolide has an established role in the management. The reason is, I told you biofilms are the aggregates of bacteria. Now, for those aggregates of bacteria to encase in a proteoglycan matrix to become a biofilm, there is a quorum sensing phenomena. Quorum means there should be a minimum number of bacteria to form the biofilms. That should fill a minimum quorum. Understand the word quorum?
Yeah.
So, that quorum sensing mechanism amongst the bacteria, that signaling mechanism among the bacteria, different bacteria to come together and form biofilm, is prevented by macrolides. That is a huge role in macrolides. The quorum sensing phenomena to form biofilms is prevented by macrolides. That's why I again call this as a wonder drug. Now, for the management. Now, once you have established on your histopathology and gram staining that there are biofilms, and you have a doubt of staph or pseudomonas, you have come to some conclusion. 100% you cannot always reach unless you have a confocal laser microscopy. But yes, with repeated culture and all this, you can reach, and mostly in the nose, it is the staph aureus. Except in certain situations like cystic fibrosis, where mostly pseudomonas. That is conspicuously in cystic fibrosis, pseudomonas is the predominant bacteria. Otherwise, in rest is the sinusitis. When there is secondary infection, it is almost always a staph aureus. So, once you have identified, the answer is sinus surgery itself is detrimental to the biofilms. Yet you can flush out the biofilms from the surface. And nowadays, once you are using hydral debrider with a jet effect on the surface, you can flush these biofilms. That's how the role of surfactants in the past used to be considered for the the biofilms. People would use, I mentioned here, 1% baby shampoo, sodium hypochlorite. What are these surfactants? So that you can evade the biofilms from the surface. We used earlier, it was 5-7 years back, I started using 1% baby shampoo, but it was not practical, was giving so much of irritation to the patient. So now, the highlighted for management. See, there are a lot of therapies you can see on the screen, which I have not highlighted, which we are not using. The highlighted ones we are using: tobramycin, mupirocin, colloidal silver, and Manuka honey. These are the 4 things we have been using in our practice in different situations. Xylitol is what? Is a 5-carbon alcohol. It has now it is coming up. I'm sure in the coming times, xylitol is going to be the #1 treatment for biofilms in coming times. A lot of work is going on. A lot of exciting results have come with the xylitol in the literature. And I'm sure this is the simplest thing which is available to everyone, which you can get. And xylitol is going to be established as a big product in the biofilm management in future. Rest we are not using. So the 4 things what we are using at what places, in what situation and how. Tobramycin, once you have a confirmed pseudomonas biofilm, we have used earlier because it is cost effective. You can use the same tobramycin injection which comes with 80 milligram. You can use 400 milligram mix in saline and douche. In the post-operative setting, you can easily douche, like you douche with a budesonide. You can mix the tobramycin along with, and it works because topical gives high concentration as compared to the systemic without systemic side effect. Then the thing, as I said, the Staph aureus is the most common bacteria. So in the literature, we found one of the drugs which is most effective against Staph aureus is mupirocin. But the thing is, mupirocin was not available in a water-soluble form anywhere. Mupirocin is available in the oil-based ointment, which cannot be mixed in saline or anything to douche. So we contacted the manufacturer and got the mupirocin powder. I mean, still using mupirocin quite frequently. The only limitation is the cost.
Very expensive.
All issues, problems, hard fight and everything, I got a mupirocin powder. The cost is 2.5 lakhs for a kg of powder. You don't give less than a kg. 2.5 lakhs for a kg of mupirocin. And what mupirocin you need is, in a liter of saline, you need 15 gram. 15 gram mupirocin, believe me, if it is Staph aureus, you douche 2 or 3 days, it disappears like anything. Lethal to the Staph. And it works so well. Those studies have given that it comes back. But what we have been doing, along with the mupirocin in such patients, we have been using macrolides along with to prevent further biopsies in the future. That's how you can strategy. Colloidal silver. Silver is an age-old product as an antibacterial agent. Silver ointments are available in the burn patient for all as an antibacterial. So now we got to know the colloidal silver is available on Amazon as a nasal spray. It is available. You can buy 800 rupees. So we have been trying this on many of our patients with good results. Safer, in a very safer doses, medical doses to be used for the nasal cavity. It is available on Amazon. Colloidal nasal spray, and you can use in those situations. And now the thing which is using most for any biofilm, now the best thing, the positive thing which we found ultimately is the Manuka honey. Once it is biofilm, whether it is Staph or Pseudomonas, anything, for any bacterial biofilm in the world, Manuka honey is most lethal for anything. So Manuka honey is a product which we acquire from New Zealand. It is a basically nectar honey which has an inherent antibacterial in it, methyl glycol. Methyl glycol is the antibacterial which is most lethal to all these biofilms. And for the medical use, FDA has standardized certain labs for the Manuka honey to be used for medical use. And Watson and Sons is the lab, and the Hill lab in New Zealand are approved for the medical use, and they have been publicizing and providing worldwide this Manuka honey for medical use. And I've been acquiring there for long. The cost is again is increasing like anything. The last one I got was 150 New Zealand dollars.
Because other companies are also there. If you go to New Zealand,
not standardized, not FDA approved.
Okay.
Not FDA approved. Okay.
So
because the publications on methyl glycol, if you see Manuka honey, the concentration of Manuka honey, you know what happens? In the acetone product in the nectar honey, on period of time, the methyl glycol content is increasing. You know?
Okay.
You have a Manuka honey and you keep it for some time. Because of the degradation of the acetone component, the methyl glycol concentration increases. And it has been proven for the nasal mucosa, the safest dose is 1.8 milligram per ml. If you use more concentration of Manuka, it is detrimental.
So, what is the concentration you use?
1.8 milligram per ml.
How do you
and this is standardized in these laboratories. They have standardized this concentration for use.
Okay, so you don't have to do any other dilution for the dilution.
No, that's why you can't afford to. You can damage the patient.
Sir, in this line, I would like to say there are many people who are asking, is the honey which we have, so it is not the honey which we usually,
No,
it's
no
not the
way.
oral intake, it is different.
Don't put honey, it will attract ants. Don't do that.
It is the
No, honey is
methyl.
antibacterial.
Yeah, it's
Though
not.
honey is antibacterial, but this is not being used as a honey only. This is because of the methyl glycol.
Yes.
Don't try using it.
Yes.
Yeah. So this is a standardized honey, which is you can acquire through the Amazon from the Watson and Hill level. Go to the Watson and Hill site, laboratory site, and you can buy.
So
these are the 4 products we have been using in most difficult situation of biofilm. Biofilm is most challenging subject. Yes.
I have a question.
Company is just for medical use, is it? They make it only for medical use.
Yes. Only for medical use.
Okay. I have a question.
Picture. This is the Watson and Son laboratory.
Okay.
Certified Manuka, and this is what you can use safely.
Okay.
So I have a question. In all these,
this is the silver sinus spray which is available on Amazon.
Okay.
Even in India, even in India, one company is there which is selling this silver solution. Indian companies is also there, which is available in the market also.
Yes, maybe, but be careful about the use for the nasal cavity. It should be nasal spray.
Yeah, spray.
Because it should not be detrimental to the mucosa.
So then I have a question that these 4 treatments that you've said for biofilm that you use in your practice, is easily available for, you just tell us, for all the people who are watching this, we want to know which is most easily available for us. Like colloidal silver, you said it is available in Amazon.
Yeah, but colloidal silver cannot deeply penetrate into the sinuses.
So then which is easily available for us if you want to use?
If you are lucky, if it is a Pseudomonas biofilm, you can use tobramycin. But if it is staph biofilm, difficult. You have to acquire either tobramycin or Manuka honey to be most effective. No other things I mentioned. See, we have tried all this, but not effective.
Okay.
So how do you distinguish, diagnose whether it's staph or Pseudomonas?
Yes, that's why I mentioned in the beginning. First, you have to establish there is biofilm by means of a biopsy.
Yes.
And gram staining. Once it is established that there is biofilm, the most difficult part is to distinguish between Pseudomonas and staph.
Yes.
Now, with the repeated cultures, sinus cultures, you will sometimes, because it keeps on releasing virulent bacteria, biofilms.
Yes.
You will some or other day pick up either staph or Pseudomonas, whatever biofilm it is, and on that guide, you can start treatment. That is not 100% efficient, because 100% is confocal laser microscopy. That is not possible. Yes. But near to 100%, if you find staph aureus in the culture, there is no doubt about it.
Okay.
And if you have Manuka honey, it works on both. That's it. You don't need to distinguish.
Okay.
So what is the concentration?
Manuka honey you can use differently also. I tell you practical way. You operated done a sinus surgery. After some days, patients come with a purulent infection all over. The mucosa is hyperemic, bone exposed, everywhere infection.
Okay.
Just apply Manuka honey once or twice. It will disappear like magic.
So how do you apply it? Like
you load in the syringe.
Okay.
And with a suction, couch section, you can apply everywhere.
Okay. Do you have to tell the patient to lie down in the dependent position?
Yes, same lying position, supine position.
Okay.
Yeah.
Okay. And sir, what is the dose you said? What is the concentration you said? 1.8 milligram per ml. How much ml you said?
Yeah. That is the inbuilt concentration in medical grade Manuka honey.
Okay.
And how long
allowed to be used for this purpose?
How long they have to lie down in that position with the honey?
5 minutes. Just apply and come out.
Okay.
Sir, there is a question from Islamabad. He wants to know what is the concentration. Dr. Talat wants to know what is the concentration of sodium hypochlorite.
We tried once, but I am so scared of using hypochlorite. I read about it, so detrimental. It can burn the mucosa. So I never use. That's why I never highlighted that. but there are literature, they have given certain concentration. Hypochlorite is an amazing disinfectant, but I have never used, and even the literature is not widespread to support it.
Okay.
I think one of the best things is
but you see, hypochlorite is amazing product. In this COVID era, hypochlorite is saving so many lives.
Yes, yes.
Sir, Dr. Rishi from Patna says that if a patient comes to you, how will you suspect biofilm?
That's why I mentioned twice.
You have to
if biofilm you can suspect clinically if patient has an obvious infection, not responding to the antibiotics, not responding to the culture-directed antibiotics, you have to be suspicious of biofilm. As simple as that.
Okay.
Osteitis.
Okay. So now we move on to the next part, again, which complicates the situation, is osteitis. And many times we see such patients, and mostly such patients come to us with revisions. I mean, who've been operated earlier. See the situation, what is osteitis? Look at the CT scan. Osteitis is what? Inflammation of the underlying bone. Because of the persistent inflammation of the sinus mucosa, the underlying bone gets inflamed. The cytokines involved in the inflammatory process invading the underlying bone, giving to this picture of osteitis. And that is one of the most recalcitrant aspect of the sinusitis to manage it. The bone full of cytokines, these are depot of inflammatory cytokines in the bone. And unless and until you remove this entire bone, nothing is going to work on it. So this is one of the most difficult situations with this disease load, inflammatory load. Almost always there are biofilms in them with persistent infection. So the answer is to remove all these bony partitions thoroughly. In surgery, see this, like in this picture, all ethmoidal partitions should be thoroughly removed.
Yeah, yeah.
Surgically, when you try to remove, you will come across the hard bone. The partitions are very hard. So you have to use most of the time the sharp instruments like through biting or silk cut forceps and all those to remove all these partitions. And then follow with a high dose steroid irrigation to combat this inflammatory load. That is the only solution to this osteitis. If you leave this osteitic bone, the problem is going to persist. It is never going to go. It is so difficult, so recalcitrant a problem. And once you get a CT like this, you have to tell your patient, you have a highest level of inflammatory load, and be prepared for the future procedures as well. Procedures and treatment.
Any separate
situation to tackle with?
Any protocol for maxillary sinus? If it is maxillary sinus wall is little, wall is important, then we have to take it out, or
you give access to the topical irrigation thoroughly. In that situation, when there is so much of load in the maxillary sinus wall, you have to do either a mega medial meatal enterostomy or a sort of medial maxillectomy. In that situation, to enable solution reaching everywhere. Okay?
Okay, got it.
Okay.
Now, coming to Pachori was question, therapies. You were asking what drugs are to be used for sinusitis. See this? Antifungal, no role. Mucolytics, no role. Decongestant, no role. Antihistamine, no role in sinusitis. Now the role comes is probiotic and prebiotic. That is number one. We give all these patients in the prescriptions probiotics. We need to understand this concept. This is the concept. Probiotics are what? I told you in the beginning, the commensal bacteria in the nose are saving us from infections. The nasal microbiome, like the overall human microbiome, is rich of bacteria. In our body, we have more than 100 trillion colonies of bacteria. You know, mostly in the gut, skin, nasal cavity, in these areas. More than 100 trillion colonies. and they are the part so important to maintain our normal immune system. So what we need is the good number of commensal bacteria, rich in number and rich in diversity. Anything affecting these is going to have a detrimental effect on the immune system. So in nasal cavity, if your commensals are destroyed, you'll have a negative impact. Probiotics is what? Is ready-made bacteria. We are giving probiotic with 10 million bacteria, 2 billion bacteria. This is ready-made bacteria to improve the overall system. And prebiotic is what? Prebiotic is a substrate which commensal bacteria use for their multiplication growth. So you can feed prebiotic for the growth of good bacteria. So prebiotic and probiotic are the part of management. It should be included.
Okay.
Bacterial lysates. You heard of the drug Bronchovaxone?
Yeah, Brahmadan.
We have been using 10 days a month for 3 months. That is what? These are bacterial antigens from multiple bacteria which were given to improve the immune system. I told you anything which improves the immunity has an overall good impact. This should be included in the list of prescriptions. Probiotic, bacterial lysate, they have role. Anti-leukotriene I have already mentioned, except AERD, no role. Immunotherapy in allergic sinusitis, allergic rhinitis. So the only drugs in entire list which work is the probiotic and the bacterial lysate for regular use in sinusitis patients. To improve the immune system, we have to improve immunity overall. That's it. I mentioned in the beginning, antifungals have no role except these situations.
Any role of mucosal barrier like HPMC spray, like methylcellulose spray or Vaseline, etc., to prevent the exposure of the allergens in your uses?
That is a topical one. See, this sinusitis is not a topical disease at one place. The underlying immune system is entirely affected. So we have to work in a systemic manner to improve the immunity. Okay. So the place of antifungals, this is important. We don't give antifungals at all except invasive sinusitis and these indications. So like in a sinusitis patient, you are operating AFRS, massive AFRS. In the pre-operative preparation, along with the steroid, you can give antifungal to reduce the load, to improve the surgical condition, to reduce the overall bleeding. Okay. Second is, in a AFRS patient or any fungal disease patient who has impending complications, we have seen many a time patient with AFRS coming with blindness, vision deterioration, vision loss, pressure symptoms. And if you have a time before surgery, you want to buy time, you can start antifungal. I remember, I give an example. Our friend Gaurav Medicari was online. His conference he organized in Bangalore. He got a patient 7 days before the conference, AFRS, massive AFRS, with the sphenoid and lesser wing of sphenoid everywhere, and patient has a visual deterioration on that side. And 6 now paresis. He wanted to keep that patient for the workshop. I told him as a good case and you can immediately start high dose steroid and itraconazole. This is to buy the time before surgery. You can use this product to reduce the load, to reduce the inflammatory load. We operated on that patient and she did very well and regained the vision and nerve absolutely normal. So you can buy the time before surgery in cases of impending complications. Post-surgical situation. In recalcitrant disease, though we don't give antifungal, but certain times, patient is on all management, post-operative, steroid using everything and is still developing problems, then you can use in that situation. And fourth is, in diabetic patients and other patients where you can't give steroids, as a steroid sparing medication in the post-op period. These are the 4 established indications for use of antifungal Rest is useless.
Okay.
Okay, sir.
Good point.
Okay. Next, we move on to the boss. You have to tell me when to stop. I don't know the time.
It's only
Sir,
8:40.
I
sir,
can keep going anytime.
so which bacterial lysates and probiotics would you prescribe in your practice?
Bronchovexone, it is not available these days. Bronchovexone is a aggregates of bacterial antigen that contains the aggregates of 9 bacterial antigens in our common practice use.
Okay.
So those bacterial antigens are used to improve the immunity against them.
Okay.
That is what bacterial lysates are. Probiotics are bacteria itself, commensal bacteria. Okay. Now coming to the different endotype of sinusitis. I mentioned different endotypes there in the beginning. AFRS is a different endotype. Why? Why it is important to understand? Why not to treat AFRS like any other sinus surgery? Because we have understood the pathophysiology of this disease. This is a type 1 hypersensitivity to the fungal antigen. Type 1 hypersensitivity means antigen-antibody reaction. Antigen-antibody reaction means like any antigen-antibody reaction in the body. What is the treatment for antigen-antibody reaction? Steroid.
Steroid.
It's a pure type 1. It is different from other sinusitis. So, and there are different criteria, you know, the widespread popular Banton-Kuhn criteria, the 5 criteria.
Yes.
See this picture of polyps with these kind of hyperdensities, a characteristic mucin, fungal stain positive, okay, and type 1 hypersensitivity to fungi. So what does it mean, type 1 hypersensitivity? See, we are exposed to the fungus. Fungus is ubiquitous in nature. If suppose for particular fungus, my body is reacting to that fungus, I am hypersensitive. If that fungus happens to get lodged in my nasal cavity or happens to get entered in my sinus, what will happen? My immune system will immediately come into action. Okay? And my immune system will come into and react strongly, and that's what happens in allergic fungal rhinosinusitis. Around the fungal antigen, the eosinophil come into action and they secrete a lot of eosinophil protein, and that particular material like a chocolate sauce is created with a lot of fungal debris and eosinophil, that classical allergic fungal mucin, and that blocks the sinus ventilation and drainage and keeps on increasing. And see how the sinuses expand in this particular situation and giving bone erosion due to expansion. That is classical or allergic fungal sinusitis. Once you have known this pathophysiology of this disease, now the treatment is easier to direct. The reason is type 1 hypersensitivity to the fungus. So we have to first remove the antigen for which the antibody is working. The body's immune system is working. So the first role in the treatment is to remove the antigen load by means of sinus surgery. And second role, since the steroid is the treatment choice, we have to do a wide sinusitis, sinusotomies, big openings to deliver the topical steroid inside. That's it. That's the role of understanding the pathophysiology. You can tailor the treatment specifically to that particular condition. So once we have understood this disease, a treatment is straightforward. Remove the antigen load by means of sinus surgery. Open up all sinuses wide to deliver steroids to combat the antigen-antibody reaction, and then you have to keep a long-term surveillance by means of wide sinusotomy. Okay. That is the treatment of choice.
Okay.
This sticky material is sometimes so difficult to remove from the corners of the sinuses in the deep areas like deep frontal, laterally, or maxillary, and we have to use many a times. I've shown the use of hydrodebrider. It's a jet by means of you can remove, because if you leave any fungus behind, the same antigen will remain and same reaction may start up again. Okay? So you have to thoroughly remove the antigen. That's why I specifically mentioned the use of hydrodebrider. Because if you leave any trace of fungus, the same story will start again.
Dr. Satish, Satish, yeah. Actually, since the AFRS topic is there, which is the, you can say, sinus emergency for, I think, most of us. So just many people are asking regarding this case. Suppose in this time of COVID, Corona time, what is your protocol for doing sinus surgery? Because so many people are asking just to ask this, what is your protocol to doing sinus surgery? Because AFRS is an emergency for us. So you are doing so many cases. You have done 12 cases today.
Understood about the COVID protocol. Everyone is forming new protocols every day. But what we have been doing, I did 3 tests today.
Yeah, I know.
This morning, I told you a list.
Yes,
So we are getting COVID testing. I don't know how reliable it is. We are using PP and all those materials to protect. And rest is left on God. You cannot do anything more, because you don't know much about this disease. Every day is a new theory coming.
Yes. Every day new protocols, new. I think we should follow the rules, basic rules, protections, and do these type of surgery, because these are the emergency.
Yes.
So Dr. Uttam Agarwal from Kolkata wants to know that in AFRS, since this is a type 1 hypersensitivity, is there any role of allergy testing and immunotherapy for fungus?
Yes, I mentioned, I was coming to that. See in the end of the slide. Sorry. See the end of the slide. Use of hybrid debrider, I reached there, and then the post-op management, as I said, steroid is the mainstay of treatment. And for these patients particularly, we give at least 3 weeks of oral steroid post-op, because this is a pure type 1 hypersensitivity. Otherwise, in other sinusitis, post-op, we don't give steroid for such long a period. At least 3 weeks of oral steroid, then topical irrigation, and then allergic testing and immunotherapy for that fungal antigen. Though antifungal immunotherapy is not so effective like dust mite immunotherapy, but still, there is no harm in giving that, and it works to some extent in certain patients. So that's a valid question. We must try the skin prick allergic testing and immunotherapy. Most of the time, it is alternaria which is responsible, and immunotherapy can work against that.
Okay. So Dr. Pranitha from Warangal, Telangana wants to know what is the best antifungal agent?
For non-invasive in these situations, itraconazole. Okay. For invasive fungus is a different goal altogether. For chronic invasive, a drug of choice is voriconazole. For acute fulminant, obviously, amphotericin.
Okay.
So that is a different thing. But overall, in non-invasive, if you are giving antifungal, itraconazole is a suitable drug.
Okay, sir. Dr. Pratik Sharma from Jaipur wants to know, in proven case of allergic rhinosinusitis, do you advise patients to use commercial available nasal filters, Nadi filter, in order to prevent the exposure to allergens?
See, I told you the fungus is ubiquitous in the nature. You, me, and everyone is inhaling fungus every day. It is your immune system how it responds. That's why I mentioned in the beginning, the fungus invades your body 3 ways, the fungal sinusitis. 1, when the fungal stasis because of the impaired mucociliary clearance leading to fungal balls. Second is immune overreactivity. Overreactivity is what AFRS. And third is immune underreactivity, immune suppression, that is invasive fungus. So it is your immune system how it works leading to the fungal disease. Otherwise, fungus we all are exposed to. Our immune system is competent enough to deal with the fungus. If there is a fault in that, we can get problem anytime.
Okay. And what is the dose of itraconazole, sir, you would give?
200 milligram a day. We don't give, some people give 200 milligram initially twice a day, but we don't use. I am not an antifungal follower that much for non-invasive fungus. We don't give much.
Okay. Okay, sir. Sir, again, one more question.
Yeah.
From Dr. Dr. Uttam Agarwal, Kolkata. For single-sided fungal sinusitis, shall we do full house? Because many times after a few years, we see fungal sinusitis on the contralateral side.
Yeah, it can happen because the pathophysiology is same. So for single-sided sinusitis, the other side absolutely normal. It is not uncommon to see unilateral sinusitis in allergy fungal sinusitis. So that situation, you have to operate on the single side, give full house space and irrigation, and if possible, fungal immunotherapy. If that immunotherapy works, it is not going to come on the other side. Otherwise, the same situation exists for the other side as well. It can come on the other side as well.
Okay.
Because the pathology remains same.
Same.
You have not treated the underlying cause.
Okay. So many are asking the same question, that what is the oral steroid dose that you prefer in your practice post-operative?
Oral steroids, first of all, my preference of steroid is plain prednisolone. No betamethasone, no deflazacort, no methylprednisolone. So all steroids are same, but by and large, through the literature, what we have found is the prednisolone. And doses, the two things: to begin with a full dose and taper, number one, and number two, to give in a OD dose. That is most effective. Like if I am giving methylprednisolone 60 milligram a day, I would never give 20 milligram TID. I would give 60 milligram OD. That is more effective than 20 milligram TID. So once you are giving some steroid, you should get optimum result, optimum effect out of that. And obviously the principle is same. You can't use oral steroids for long, so you have to taper down it with time.
Okay. Okay, sir. So do you give steroids in AFRS with diabetes patient? Dr. Pratibha from Thane wants to know.
Oral, not for long. I told you steroid is a limitation in diabetes. But yes, topical you can give for long. Topical has no effect on the blood sugar concentration because there is hardly any systemic absorption.
Sir, Dr. Kaustubh from Guwahati wants to know that more about hydrodebrider that you had mentioned.
Video. Okay. Next, when surgery session, we will show a case.
We'll talk
video.
about hydrodebrider.
Next week.
Hydrodebrider. But yeah, it's a jet. Yeah, so you can disrupt the biofilm. That's the added advantage with that. And you can remove all material. Particularly in AFRS, like you have to remove each and every antigen, possible antigen, that is fungus. Which is a huge role in that. Particularly in difficult, in the last Agra conference,
yeah, we saw it.
I used the case with a massive fungus in the front of hand, which was otherwise difficult to remove.
Post-op ultimate.
So in certain indication, it is useful.
Okay. Okay, so said Dr. Arun from Andhra Pradesh wants to know just the protocol of amphotericin for invasive fungal sinusitis.
Invasive fungus, we'll discuss in the next session in the radiology about the invasive fungus. But yes, once you have asked, amphotericin is a drug of choice for invasive fungus. We'll know. I tell you, this is an important question. How to use amphotericin properly? And this is a big, I would say, drawback. People are not using it optimum. For amphotericin to be used, we use lyophilized amphotericin, liposomal amphotericin, and our dose is somewhere between 3 to 5 milligram per kg per day. How you can use? If you want to note down, you can. We use a liposomal amphotericin. Suppose a patient is a 60 kg patient. So in 3 to 5, somewhere you have to use 200 to 250 milligram. Each amphotericin vial contains liposomal contains 50 milligram. Suppose you are giving 250 a day, then 5 vials of 50 milligram. Okay? Now you have to dilute this. For every vial, you have to use a separate syringe. Use not saline. Saline is contraindicated to be mixed with amphotericin. That is important. You have to use distilled water. Okay? Distilled water. What I will do, for 50 milligram, I will use 12.5 milligram of 12.5 ml of distilled water to dilute. Okay? Distilled water. That much of distilled water to be mixed in the amphotericin powder.
Okay.
And mix it well until the all particles are invisible.
Dissolve.
Completely dissolved. You have to mix thoroughly. Throw away the syringe, use the next new syringe. Take those 12.5 ml from all 5 syringes, 4 or 5, whatever, how many vials you are using. Suppose 200 milligram, 4. That means 50 milligram. Now further dilute that 50 ml. Further dilute that 50 ml into 200 ml of distilled water and infuse IV for 2 hours.
Okay.
Every time different syringe, every time completely dissolved powder. There should not be any agglutination.
Okay. Many people are waiting for this aspirin desensitization and this thing.
Yeah.
Okay, that is the next one.
Yes, sir.
So first, I mentioned this about this particular subject.
Aspirin.
This is the most severe aspect of any sinusitis you can think of. Most recalcitrant, most resistance, every form you can label to this aspirin exaggerated respiratory disease. So to treat this disease optimum, again we need to understand the pathophysiology. That's a different endotype. I told you every endotype has a different treatment and we have to tailor accordingly. Like we understood the AFRS, we tailor the treatment accordingly. This AERD, we need to understand the pathophysiology. What happens in our body when the body phospholipids are degraded, arachnoid acid is degraded by means of cyclooxygenase enzyme. It is degraded preferentially to the prostaglandins, which are anti-inflammatory. This is what normally happens. And very less of the arachnoid acid is degraded by lipoxygenase into leukotrienes. Very less. Rather, prostaglandin blocks lipoxygenase and only good prostaglandins, anti-inflammatory, are formed in every day. Now, what is cyclooxygenase? What is aspirin? What are NSAIDs? They are COX-1 inhibitor. That is cyclooxygenase inhibitor. Now, the patient who is sensitive to the aspirin, that is cyclooxygenase inhibitor, COX-1 inhibitor, what is going to happen? Prostaglandins will not form and leukotrienes will form in abundance.
Excess.
Lipoxygenase will aggravate and more leukotrienes will form, less prostaglandins, the blocking effect of prostaglandin will be over and lipoxygenase will be unblocked. And more leukotrienes will form which have immense inflammatory activity. Leukotrienes are most inflammatory agents by means of attracting eosinophils, by means of giving vasodilatation, smooth muscle contraction, edema and all those things, and give the most severe aspect of sinusitis. Most severe aspect of asthma. I told you these patients have polyps as well as asthma. And both because of leukotrienes. And that is like Dr. Riaz asked from Pakistan, where is the role of Montelukast? Montelukast is what? Leukotriene receptor inhibitor, and that is the key role here. So this disease is a leukotriene driven disease which attracts eosinophil and all this. On all this entire thing, still the steroid works. Steroid is the only thing which works, but that cannot cure the pathophysiology of the disease. Now, having understood this pathophysiology, now we can accordingly target our treatment. So treatment is, the key treatment is to block this COX-1 inhibitor hyperreactivity, hypersensitivity. And for that, you need to desensitize with the aspirin. That is the treatment. So the overall management consists of, first of all, do a full house test and remove the inflammatory load. All leukotrienes, eosinophil you have to remove completely. Lipoxygenase inhibitor is dilute on, so that less leukotrienes are formed. Whatever leukotrienes are formed, for not allowing them to act on the receptor, we have to use Montelukast, which is a receptor inhibitor for leukotrienes. Okay, you have to use less salicylates because salicylate is reacting. So we have to ask patient to use less salicylate diet. And what you can use as a painkiller is COX-2 inhibitor, which is not hypersensitive patient with. That is celecoxib. That is the drug of choice as a painkiller. You can use paracetamol also, which is a low COX-1 inhibitor, but as much as possible should be avoided, and celecoxib should be given as a painkiller. And the drug and the treatment of choice is aspirin desensitization. Now, aspirin desensitization is a huge procedure. It is not a simple choice, simple treatment. There are a lot of implications of aspirin desensitization. It is not all that easy. So first of all, before doing that, we have to establish the diagnosis that this is a confirmed AERD. Obviously, the history tells. Now, there are ways to do the aspirin testing. Nowadays, we are doing even skin prick testing also. We got the solution. Otherwise, oral aspirin, you give oral aspirin and you get symptoms, including bronchospasm. That is threatening, life-threatening. You can't do that. On safer side, you can give a bronchial challenge with aspirin. You can give a nasal challenge with aspirin to get less severe symptoms. But what now we have started doing is, forget about all these challenges to save the patient. What happens in this situation? Leukotrienes are forming in abundance. So we get the urinary leukotriene level. If it is too high, that is obvious the patient has an AERD. As simple as that. You don't need to do all these funny challenging tests which are detrimental to the patient. The best is to do a urinary leukotriene. LTE4, you test the urinary LTE4. If it is high, that tells that patient has an AERD. With a history in the background, with history of asthma and polyps, there cannot be anything else. Okay? So the best and the simplest way is to get a urinary LTE4 test. Most practical. Now, once you have planned a desensitization, you have to start oral aspirin. Now, once you have planned oral aspirin, it has to be always done in the post-operative setting. Because once you start aspirin in the pre-op, you can't operate. So first do a full house fast. When the healing takes place, reasonable, until then the steroids are given. Now, once you start desensitization, once you have to give oral aspirin, you have to be prepared to deal with every possible reaction that can precipitate even a severe asthma. So what all you have to do is, before that, you have to start the Montelukast a week before to reduce the load of leukotrienes to prevent severe attack after giving oral aspirin. Okay? So you have to blunt the reaction by means of starting Montelukast a week before. You have to load with the Montelukast. Then still the reaction can occur and it can be life-threatening. It can precipitate a status asthmaticus even in the patient. It has been reported. So it has to be always done in an ICU setting with a in the pulmonologist and intensivist care. So you have to counsel patient to get admitted in the intensive care setting under intensivist and pulmonologist to get ready for the oral challenge.
Yes.
That's why I told it's not all that easy. With all consents.
Sir, in your practice, how many percentage of these cases do you see?
Many. We have more than 250, 300 patients now on desensitization.
Okay.
So it has to be done in ICU setting. And then once the patient is admitted, you have to start with a low dose of aspirin, oral aspirin with all resuscitation measures ready. The beauty, the funda behind desensitization is, on which this is based, is once you start oral aspirin, the reaction will happen to occur. But after that, there is a refractory period of 2 to 3 days. In that, in spite of increasing the doses of aspirin, the reaction will not increase. That is the beauty behind this particular phenomena, refractoriness, which allows us to increase the dose of aspirin over the period of that time. So we start with 30 milligram, reaction occurs, the nasal symptom comes, the lower airway symptoms come, give bronchodilator, steroid, everything. The symptoms are taken care of, and then keep on increasing the dose of aspirin from 30 to 60 to 90 to 120. In 3 days' time, raise it to 300, and because of that refractoriness, patients start tolerating the aspirin after that. So in 3-4 days' time, when patient is able to tolerate aspirin up to 600 milligram a day, you can discharge. Now it is such a safe situation. You are giving aspirin to the patient and he is tolerating so well. What else you want? And once patients start tolerating aspirin, the prostaglandins have started forming and leukotrienes stop. The entire pathology is reversed. But my point, that is the value of understanding the pathophysiology. That is a different endotype, and that is the treatment. In such cases, don't treat on this line and keep on doing sinus surgery. You operate 100 times, the patient is ready again with the same problem.
That patient has to take aspirin for lifelong, or how much dose you give?
Yes, that is important. That is something difficult thing. What you can do, what we have done, we keep on reducing the dose of aspirin. Literature says up to 300 milligram a day is safe. We have been able to reduce up to even 100 milligram under close follow-up, and patients are doing well. The only issue is everybody is not able to tolerate the aspirin so easily for life. It can lead to peptic ulcers, bleeding, so many things. Though aspirin is widespread in use in cardiac patients, elderly patients, but still the complications are there, particularly the gastric ulcers and all that. So those are the most difficult patients which are difficult to treat. And you may have to stop the aspirin. Otherwise, is the treatment to treat the underlying cause. This is sinusitis, but a different endotype. So this is the time of precision medicine. Time is of precision medicine to treat the underlying pathophysiology of particular patient disease, not the treating sinusitis as a whole for every patient same. That cannot work. That is the reason behind a lot of failures in this disease. And my aim today was to give that message that every sinusitis you have to thoroughly evaluate. Every sinusitis is a different pathophysiology. You have to thoroughly use the diagnostics, and thoroughly treat the comorbidities, thoroughly use the drugs cautiously. Many of the drugs are not working. You can find number of drugs in the prescriptions of the doctors. You may please pharma companies and all, but they don't work. You have to understand the disease, what to use, what not to. That is the core message I wanted to give.
Yes.
So do we continue?
Yes, sir.
So how much slides are left? How many slides are left now?
400.
So
I think we can continue. I think later.
Yeah, we can continue. Let's still more than 1,000 people are still there.
Oh, really?
Yes.
Yeah.
Okay.
There are.
So I hope so far the things are clear.
Yeah,
Yes.
Before I move forward, any questions?
I think we can carry on with the slides. I think.
Yes, I'll carry on with the slides because these questions you've answered all the questions.
Okay. So now, again, the big question is whether surgery or whether medical treatment. Always I told you the trade-off. So this was the recent guidelines by the UCLA that when to take a call of surgery. And this is simple to understand. I told you to use the SNOT 22 in the beginning. So what you can do in a polypoidal disease, saline irrigation, suppose 8 weeks, steroid topicals, short course systemic steroid, and after that assess with a CT scan with the scoring whether it is reduced significantly or the SNOT 22 score whether the symptoms have gone down. If it still persists, then take a call. As simple as that. In both polypoidal and non-polypoidal, we have already discussed this. So finally, you have to take a call of surgery based on evidence. Not based on experience, not based on will of the patient, not based on will of the surgeon. It should be based on the evidence that this is the indication for surgery now. Is that clear?
Yes.
Yeah.
So once it comes to FES, we all know there are indications for sinus surgery, there are indications for preoperative management, indications for appropriate medical management before surgery. Everything is there. But there are certain situations where you can bypass all this and you can go ahead with the FES directly. I see a patient today and I can operate tomorrow. These are exceptional situations which I want to mention here. Number one, the patient has an impending complication, intraorbital, intracranial, then you don't have to wait. You don't have to wait to give appropriate medical treatment. You don't have to wait to optimize the surgical field by preoperative medication. You can go ahead. This is most important. Then fungus in any form. Fungus in any form is an antigen. We have discussed. And in order to get rid of the disease, you have to remove the antigen. Otherwise, it will persist. Whatever medical treatment you give to a fungal patient, it is not going to cure the fungus. So ultimately, it's a surgical indication. You don't need to give appropriate medical treatment. You don't have to wait for 8 weeks, 12 weeks. Once you have seen fungus means, that's it. You have to operate. It's a clear-cut indication. Then another form of sinusitis is odontogenic. That's a different endotype again. I would call it a different endotype. The reason is, this is pure infection. In contrast to the other form of sinusitis, which is all inflammatory. In other sinusitis, we have seen eosinophilic driven, a different pathophysiologic mechanism, AERD, AFRS. Odontogenic is a direct contiguous spread of infection to the sinus from the infected tooth. In that situation, you have to remove the underlying cause, the tooth, and treat the sinusitis at the same time. You don't have to wait for appropriate medical management. So that is sense different. Clear? Then mucoceles. Mucoceles are what? Simple blockage of the sinus drainage. And the retained mucus secretion with obstruction of the drainage will keep on expanding the sinuses, and many a time patient present with a pressure symptom until they get large mucoceles. But it is not sinusitis. There is no inflammation involved. No pathophysiology of sinusitis involved. It is simply because of blockage of outflow of the sinus. It's very common in frontal sinus because frontal is so strategically located in the unfavorable situation with a lot of cells in the frontal recess, lot of variability in the frontal recess cells leading to the obstruction. That's why the frontal mucoceles are most common. And that is a straightforward surgical entity. These all listed are the straightforward surgical entities. That's what I have brought them together without needing appropriate medical management. Anatomical variants, straightforward. See now, how to understand this. If you get a patient with acute sinusitis, you got the scan done and on endoscopy you found a concha bullosa. Obviously that is compromising the sinus outflow and drainage. Yes, you can treat on the medical grounds, give antibiotic, steroids, saline wash, decongestant, it will improve. Okay? But what will happen? You're not treating the cause. That is predisposing to the sinusitis, blockage of the sinus. It will again come back. Again, he will develop, again you can give medical treatment and improve, but again and again he'll come back. In such situations, you have to be wise and take a call in the beginning to counsel patient. Since you have a cause which is treatable simply by surgery, anatomical cause most favorable in terms of outcome, though you will improve with the medical treatment, yet there is indication for surgery to prevent recurrences. And this is a different story from other sinusitis situation which we discussed so far.
Yes.
So in that situation, the counseling is different to the patient, and this is most rewarding to the surgeon. You remove the anatomical factor, and patient get rid of sinusitis forever. So in such situation, when there is so rewarding a pathology, we should not think twice before operating and give patient a lasting relief.
Okay.
Now coming to the gray zone. Gray zone is what? Where you don't stick to a fixed formula. You have to take a practical call. Practical call means a patient coming to you with messy polyps. Polyps hanging down in the nasal cavity. Polyps in the middle meatal minimal. Polyps occupying the meatus completely, and polyps hanging down in the nasal cavity going to the nasopharynx or coming out of the nose. Massive polyps, yes, medical treatment is warranted. You should start topical steroid, saline irrigation, you should try. But in our heart and hearts, we know the inflammatory load is so much. This is not going to go with the medical treatment. The inflammatory load is so much, it is not going to be taken with a topical steroid again, when already there are so massive polyps. So that you can skip and go on to the direct phase if the patient is properly counseled. This is your practical call, because you know in your heart this is a huge inflammatory load. There's no point in wasting time in few months in medical treatment. Rather, patient may fall upon you if you don't counsel. Doctor, you have been giving me unnecessary medication for 4 months and now you are telling me surgery. Why did you give me all this? Why did you operate in the beginning? So you have to consider all the aspects and tell your patient should be taken into confidence first to take a call. So it's a practical call. That's why I called it. It's a gray zone.
Okay.
And
Yes.
again, one more situation in the gray zone. That is, like George was asked in the beginning, patient asking repeated oral steroids to control the symptoms. To me, in our practice, this should be, and this is the number one practical indication for sinuses. Any patient requiring oral steroids again and again to control the symptom, what are we waiting for? We have to make him use the topical steroid and avoid oral steroid by means of a sinus surgery. Simple. And that is the indication. That is the indication for the sinus surgery. So we have to understand what is the gray zone when to take a call for sinus surgery. Sometimes you have to be practical. So any patient requiring oral steroid and again, simply is the indication for sinus. Whatsoever the radiological situation, that patient may not be having a huge radiological disease. The CT may not show a sinusitis to warrant immediate surgery. Maybe showing minimal disease, but that inflammatory load is too much to warrant the need of oral steroid again and again. So that is a practical call again for sinus surgery in those situations, rather than giving oral steroids again and again. Is that clear?
Yes.
So here Dr. Monish Grover wanted to ask you, to deliver these medicines, would it be recommended to sacrifice middle turbinate?
Hey Monish, not slept yet. So champion, can you repeat the question?
To deliver medicine post-operatively, do you recommend to sacrifice middle turbinate like in ethmoid turbinectomy specimen?
Yes, that's a question from a champion. That's a
new concept. It's a new concept, I think, in present scenario.
And it is valid. The reason is, see, post-surgery, our goal is to make sure that our topicals reaching everywhere freely to prevent the disease coming back. So our goal is to ensure the topical reaching everywhere. Now, in the massive mucosal disease, massive mucosal pansinusitis, polyposis, Middle turbinate sometimes becomes a problem in preventing the solution to reach everywhere. It is not the turbinate which is the site of disease. Turbinate will not develop the polyps, but it becomes a problem in not allowing the solution to reach freely to the sinuses. And in those situations, if given a situation to me, I am dealing with a massive mucosal disease, I would prefer to do a sort of turbinoplasty, a partial excision of the turbinate to allow the solution to reach freely to prevent the situation of recurrence, warranting revision surgery. So it's a practical approach to resect the turbinate in a planned way, in spite not needed, but it's a practical approach to prevent the recurrence in those situations in massive mucosal disease, and lots of papers, lots of publications there available to support this this theory. And it's a valid way of knowing this.
Yeah. I mean, I think that we have reached up to direct fast cases. Now I think still we need. And now the next lecture, I think you want to. I think is anything left regarding, because of you have to now. I think next would be the post-op care and pre-operative assessment.
Then move to the surgical part in the next.
Then we can the radiology also, and so many things are there.
Sir, I think for the question answer series, we should actually have another 2 hours, because there are almost 600 questions. And really? I'm really sorry. Yeah. And I'm really sorry if I cannot read all of them, because there are so many and I'm missing so many of them. So I think for question answers session, we should have separate 2 hours. We should ask Sun Pharma to do that for us.
I request all them to direct your question to Dr. Paramita. Flood her mobile with the question.
So I'm really sorry. I cannot attend all of them. I could not attend all of them, in fact.
We will take them in, and next time we will ask those questions in the starting, or
yes, we can take those questions next time also.
Yes,
first half an hour.
Yes, first half an hour we can. I'll just filter out few questions, and we can discuss these questions in the next session.
So write it down, and next session on Sunday 5:30 we are starting. First half an hour we'll give it to the question answer. Again, then we'll go for the further like radiology and pre-operative assessment and post-operative. Then next on Thursday, most probably we'll go for the surgical session. And for all, I think we are planning to go for cadaver dissection also on webinar and the live surgery. But I think this Sunday 5:30 we are planning.
So the most interesting question out of the 600 questions were from Iraq. Dr. Hemin Shabir is asking, how old are you?
Me? How old I look like? Very old.
Yeah.
That's how to guess.
So we'll start with this question in the next session. This will be the first question.
Okay.
So seriously, next session, first half an hour, we'll choose the questions, and I think I request all of you to be there. Those who have asked the question, and we will give the answer as in a better way and in a summarized way.
Actually, I think Paramita can filter the questions, because they're repetitions.
Yes.
Yeah, we can, and the answer will be given in a different means, in an authentic way, or we can say in a live ways. We can show some good points also with the literature also.
Yes,
is it? I think we can follow.
So today, to summarize, you would like to summarize in few sentences, or will I do it something that you can make some corrections if you want? So basically, so you have told us a lot about diagnosis investigations today, like serum eosinophilic count, serum IgE. Especially in this, we got to know that if it is normal or low, then 80% don't need surgery, right? We should give we should be giving macrolide as a treatment.
In selected patients, not in elderly and systemic disease patients.
Okay, and if serum IgE is high, then
IgE is high, then it is eosinophilic disease or allergic, or if not allergic, then staphylococcal infection.
Okay, so CRP, another investigation we'll do is CRP. Okay, then if it is normal, we won't give any antibiotics. We'll also go for vitamin D, which you said is very important. It is a main
particularly in polypoidal disease.
Yes.
And secondly, in patient with repeated infection.
Okay. Yes, sir. And then the histopathology. that you said?
Must.
So
All patients by default.
Yes,
like we do histopathology for all other patients,
yes,
tumors and all. It
yes,
should be, it gives you the profile of the patient, the kind of severity of the disease he is having. It dictates the post-operative treatment.
yes,
And this is the big evidence of the disease of the patient. In
yes,
case of recurrences, you should have it has a medical legal value as well.
yes. So
And they can get a printed format of histopathology form, and they will keep it with them. And, yeah.
Yes.
No, they can upload over there. Next time we'll upload it. They can,
Two important things that we see in the histopathology is the basement membrane, you said, and the eosinophilic count. Right?
Yeah,
and bring in practice the SNOT 22.
Yeah,
Sorry?
it's not 22.
Okay. And then the aspirin sensitivity test that you said, it is
Selected patients.
has to be done in selected patients.
Don't try to treat all sinusitis in the same line. They're never same. Every sinusitis you have to thoroughly investigate to reach to the pathophysiology so that you can tailor the treatment accordingly. It is a time of precision medicine, not like treating everything on the same line.
Okay.
And what we have started in our practice, that we have printed out is not form, and we are giving to the patients also, post-op cases. So they have a good compliance, and they just come every 2 months that, okay, I have improved so much.
If you are regularly using SNOT, pre-operatively, post-operatively, every time, you'll never be in medical legal issue ever in life. That itself is protecting, because in that situation, patient is always a part of decision making.
Yes.
Okay. And then the management options, as you said, corticosteroids, then the phase surgery and the targeted therapies.
Targeted therapy is the future. That's just to establish. Reasons I have already given.
Yes. And then with the chronic rhinosinusitis with nasal polyp and without nasal polyp, the main difference is the oral antibiotics. With nasal polyp, you said that doxycycline is more effective.
You can use as an adjuvant.
Adjuvant.
Not first line treatment.
Without nasal polyp, you said macrolides.
In selected patients, yes.
Okay.
And I think, and for the COVID, your final judgment, just for the COVID cases, because these people should go for elective surgery or no, or they should go for only emergency surgeries. What's your take of? Because the many questions are there regarding COVID.
Nothing is understood about the COVID much. I believe there is a lot of nobody knows. So we are. I told you that taking all precautions and doing, God only knows what is right, what is wrong.
Yes, that's true. So I think we, any comments from Dr. Varghese, sir?
Yeah, that was a very informative session, and I think Satish has covered almost all the aspects, and it was worth the time.
Yes.
Thank you.
Thank you, boss, for being with us.
Thank you
all. Thank you, everyone, for sharing your valuable time and
it was a real
sharing with me.
So we will meet on Sunday 5:30, and regarding radiology and few more points that we will decide.
Yeah,
so I think
we'll start with the second part of the.
Yeah, second part with starting with the question answer and followed by radiology and other things. Yes. So we can call off for the day, and I think very much I would like to thank Dr. Satish, Dr. Varghese sir, Dr. Paramita, and all the audience. I think they were. It was a record-breaking attendance today, and most of them were out of India. And it was actually even 5 minutes back, the number was almost same. So it's amazing. It was
almost 1,300 people are still witnessing you, sir.
Yeah, just now. So I think let's thanks to Sun Pharma also, and Mr. Puneet is managing everything. And thank you very much.
Thank you
so much. Keep yourself safe and avoid unnecessary things, and keep yourself safe. That is the main thing. Thank you very much.
Thank you.
Good night.
Good night. Good night.
Good night.
Thank you. Thank you all.